to the diabetes world and keeps diabetes firmly in the public and political spotlight. The World Diabetes Day campaign aims to be the platform to promote International Diabetic Federation advocacy efforts throughout the year. Global driver to promote the importance of taking coordinated and concerted actions to confront diabetes as a critical global health issue. The campaign is represented by a blue circle logo that was adopted in the year 2007 after the passage of the United Nations resolution on diabetes. The blue circle is the global symbol for diabetes awareness. It signifies the unity of the global diabetes community in response to the diabetes epidemic. Friends, every year, the World Diabetes Day campaign focuses on a diabetes theme that runs for 1 or more years. And this year, the theme for World Diabetes Day 2020 is the nurse and diabetes. And we have an eminent personality today for representing nurses today to focus and also to give awareness for us. And friends, we have a galaxy of faculty present today to elaborate on diabetes and its complications and treatment, everything, under the leadership of Rotarian Arun S. Menon. And I am not taking much of your time. I thank you all for joining for this wonderful seminar. Thank you very much. Thank you all.
Thank you, VG. RI Director-elect Rotarian PDG Dr. Mahesh Kotbagi is the chief guest of today's seminar. Let me invite District Trainer, Rotarian PDG, PG Muralidharan, to introduce our chief guest.
Beloved District Governor, Dr. Thomas Vabani Kunnail, and Chief Guest, Dr. Mahesh Kotbagi, and my dear friends. We have the privilege of introducing Dr. Mahesh Kotbagi, Rotary International Director-elect 2021-23. Dr. Mahesh Kotbagi is a professional hospital administrator and chairman of Kotbagi Hospital Private Limited in Maharashtra. He is a fourth-generation medical practitioner. His grandfather was the physician of Mahatma Gandhi. He is a postgraduate with gold medal for his thesis in MD Gynecology from University of Pune. In 1991, he established a 10-bed hospital, which soon grew to a multi-speciality hospital. He has established Chinmaya Medical Foundation Charitable Trust to support low-cost healthcare services and to support the education of rural children. He has also established a low-cost dialysis center. He has served as honorary professor in several medical colleges, member of Senate of Pune University, and trustee of Medical College. He has business interest in healthcare, hospitality, petroleum, and construction industries. Dr. Kotbagi is a member of Rotary Club of Pune Sports City, District 3131 in Zone 7. He had served Rotary International as District Governor in 2005-06, International Training Leader 2014, Chairman South Asia Literacy Summit 2014, ARFC 2017-18, and Guest Chairman 2020. Currently, he is co-chair of Rotary India Literacy Mission. He was Rotary Volunteer of Medical Mission to Lesotho, high altitude, landlocked kingdom encircled by South Africa. He has given leadership to more than 100 service projects in literacy, polio surgeries, rubella vaccination, cow banks, and rural women and welfare of special children. He has been honored by Service Above Self Award by Rotary International and Citation of Meritorious Service Award by the Rotary Foundation. Mahesh and his wife, Dr. Amita, are third level major donors and benefactors of DRF. Ladies and gentlemen, put your hands together in welcoming Dr. Mahesh Kotbagi, Rotary International Director-elect 2021-23. Thank you.
Thank you, PDG Muralidharan. Now, we will have the inauguration of World Diabetes Day District Seminar by RI Director-elect Rotarian PDG, Dr. Mahesh Kotbagi. Inviting you, sir, for the inauguration and inaugural address.
A very, very good evening, friends. My friend and the District Governor, Dr. Thomas, and of course, the District Trainer, PDG Muralidharan, PDG John Daniel, and so many friends from District 3211, along with moderators, faculty, doctors, paramedical, and of course, all the Rotarians who are here. First of all, let me begin by declaring the inauguration of the World Diabetes Day has been inaugurated today, especially on behalf of the 3211. Friends, this is a very, very concerned and a grave topic. When you must have heard with Dr. Thomas what he was saying, I think he gave you the entire preamble. And I'm very happy that the Rotary has taken up this program as a movement. You know, there's a lot of myths, and one of the myths is, how does diabetes happen? I'm not going to tell you all the scientific story, because you heard in my introduction that I'm a gynecologist. I'm not an endocrinologist or a diabetologist, and where the competent panel is going to tell you. But people often mistake how diabetes happens. I was just, in terms of humor, I also thought sometimes that diabetes also happens if you talk too much sweet. And that's what it happens in Rotary also. Once you join Rotary, you learn to talk very, very sweet. If you become a past president, then you also become more and more sweet. And if you become the past district governor, then it is the peak of the sweetness. And I think that's the reason I think PDG Muralidharan, he spoke so sweet about me as a speaker today. Friends, let me tell you, you all belong from a country. I always say the God's own country. I've been, very, very fortunate to visit your district and your neighboring district a couple of times. One of the most admiring state. And whenever I feel claustrophobic in cities and metros, I always feel like escaping and come to your places and sometimes meet my friend John and then go in a nice boat in the backwaters to just, refresh, re-stress and, some kind of, I can say that do the yoga siddhi over there. I think today's subject is a similar subject. When you read all the statistics, 1 out of every 10, that is right around about 10 to 11% people suffering from this grave disease. And this is something, a blood pressure and a diabetes or in a combination. It is something like, one's life can be totally changed. So I think this preventive program and making this awareness program through the World Diabetes is an extremely good concept. And this concept has been since 91 people said about it. But it's very important to understand that around about 463 million adults were living in diabetes in 2019. So roughly we are talking about 500 million people right now which exist with this kind of a disease. And I think Rotary is all about making the prevention, making all about the awareness of that. I just went into the 5 components where you as a Rotarian, you as a volunteer, or you as in general can work and support this particular activity. One is you can have the screening camps, which is very important. Today to screen for a diabetes is a very, very low cost model. In fact, there are so many, diagnostic companies which offer these screening tests at absolutely nil cost or even at a very, very merely subsidized cost. So screening is one of the most important subjects. Although only screening is not going to help, because once you screen it, you have to have the right type of a treatment. Most of these patients, they have the type 2 diabetes. But it is very important subject to understand what kind of a diabetes it is, at what age you have got it, whether it's a juvenile diabetes, whether it is age-related diabetes, whether it is a diabetes because of only diet, or whether it is something which is related to the pancreas. So it is very, very important that you understand which diabetes and which treatment to go on that. The third and more important subject which I thought is exercise. Today we live extremely sedentary life. At least in your part of the state, people still have places to walk. People still have, mountains to see. People still have the lakes to enjoy. But there are cities in the world, or the metros, which hardly have any space even to do the exercise. But in spite of that, to do exercise and to burn your fat, to burn your calorie, and to be fit is one of the best remedies which I have always seen in patients. And diabetes is nothing away from that. Fourth is the total stress environment which people live today. The stress is one of the biggest killing factor for this particular disease. Even how to release the stress, I think the entire Yoga Siddhi, which has been, yoga or Ayurveda, which is a part of Kerala, your land is one of the masters in terms of yoga, in terms of, all the Ayurveda and all the best therapies. So I think that is also one of the best ways where it can be, controlled. But people often also do some mistakes by giving a wrong treatment, or just by believing into the naturopathy. When there is some severe or acute problem, people have gone into the bigger emergencies to the extent of septicemia, or even to the amputations, or even the vascular surgeries. So one has to understand at what level we can, afford to do only the preventive treatment, and at what level we can go for the curative treatment. So it is, I think, all a part of learning process for this particular disease. But I think these diseases are, very, very becoming common and common. And it is nothing bad to very, very openly accept that this has happened to me, this happened to you, or this can happen to anyone. So be vocal on this subject. Once a year, those who are plus 50 years, I always recommend them. All those who are above 50 years, they should do this simple test of blood sugar fasting and postprandial. Or, there are also some tests where you can understand early detection of diabetes, where the panelists will tell you something like H1B1C, which will give you, some percentage or some parameter to understand whether you are in the right frame or not. So I think, ladies and gentlemen, today is the day that the mission to participate in curative manner is begin. And I think, Dr. Thomas, you have done this wonderful initiative, and I congratulate you and the entire team, and of course give my all best wishes to this successful program. So may God give great, blessings, because you are going to, help people and do good in the world. Thank you so much for inviting me. Thank you so much.
Thank you. Thank you very much, Dr. Mahesh ji, for your presence and motivation and encouragement for our Rotarians. Thank you so much. Thank you so much.
Now, let me invite Rotarian PDG, Dr. K. Vijay Kumar, Zonal Coordinator, for his remarks.
Vijay Kumar is not in the meeting, it seems.
Vijay Kumar vanilla.
Yeah.
Then you can call Dr. Ajay. Dr. Ajay.
Okay,
Vijay,
now
I think Vijay Kumar is in at Coimbatore.
Okay, go ahead, Syaji.
Yeah. Now we'll have remarks by Rotarian PDG, Dr. Ajay Kumar, Zonal Coordinator.
Good evening, everybody. Am I audible?
Yes,
Yes.
sir.
Yes.
District Governor Dr. Thomas Kunel, Chief Guest Dr. Mahesh, all the leaders of District 3211, the past district governors, president secretaries, my good friend Dr. Harish, who's the chair of your district. Of course, I should not forget Moulail and Tessie, who have to be my very close friends, sisters. My sister's classmate is Tessie. So I'm very much related with this District 3211 and really proud to be one of your zonal coordinators for this positive health program. Before I say anything, I should congratulate our RI RI Director, Mahesh, for getting elected to this great post. I'm sure, sir, with your experience and your knowledge, you will do wonderful things for our districts in the years to come as RI Director. And I wish you all the very best, because the first time I'm able to talk to you directly in front of an audience before after you got elected as the district RI Director. Congratulations, and I hope and pray that you will do very wonderful things for Rotary in future. Thank you very much. Dr. Thomas, I should really congratulate you for the wonderful leadership you're giving to 3211 during the times where COVID is really spreading and really taking a lot of our time as well as energy. The November 14 program, which you, with the help of your district chair, Dr. Harish, has done, has reported to me, and I should congratulate you and Harish and all the assistant governors and the coordinators, and especially the president and secretaries of your clubs, who have done a wonderful job in seeing that this awareness of diabetes is propagated to all over your district by each and every club. Congratulations to each one of you. Friends, you know, India is the diabetic capital of the world. No wonder our RI directors, Bharat and Kamal, have given us this program of disease prevention, and definitely this is one of the in things in Rotary. Most of our clubs throughout India are doing wonderful job in this aspect, in prevention of these diseases and creating awareness for all these, especially diabetes, hypertension, ischemic heart disease, cerebrovascular disease, cancer, as well as cervical cancer and respiratory diseases. This is the most important thing, because I told you, India is the diabetic capital of the world. Unfortunately, our God's own country, Kerala, is the capital for diabetes, where maximum number of diabetes are seen here. It is very important that we recognize these diabetes as early as possible. There is a condition called pre-diabetes. If you can identify them early and then give them the exercise, the advices to see that this diabetes does not present itself for a little more time or is postponed to a certain time, I'm sure you can prevent the complications of diabetes, which is very, very awesome. Definitely, that will give you a better health, so much of monetary benefits, and definitely prevent the complications of diabetes. It is with this in view that our RI directors and Rotary International India is going forward with this preventive health program. It's not only for diabetes. Diabetes also leads to cardiovascular diseases, cerebrovascular diseases, and all of types of diseases, because this is a combination and a huge program together in itself. Friends, today we have got a fantastic panel arranged for the seminar, and I'm sure I should not stand before you enjoy your seminar as well as get the knowledge from all these expert panels which is there. I also should congratulate Dr. Arun Menon, a colleague from Glissy Hospital, who is going to be the moderator, and I'm sure all the team members there will give you wonderful understanding of diabetes, how to prevent it, how to postpone it, how to give the treatment for this, and all the other aspects of diabetes, so that by the end of the seminar, District 3211, under the leadership of Thomas, would have become enlightened by this diabetes and definitely do wonders in the coming years to see that this disease can be prevented or postponed in the best possible way. Once again, I thank you for giving me this opportunity, for inviting me to this seminar, and always also for all the cooperation you have given me in my job as a district coordinator for health, preventive health, during all the seminars which you have conducted, as well as all the programs. I look forward once more for all your cooperation in the remaining year for all the other programs to be held on other different days to come. Thank you very much. Once again, I have to thank Jojo for the wonderful work he's doing. And definitely, Jojo, you are really the pride of this district, because you have organized things in such a wonderful way with your presentations during these seminars as well as these wonderful programs you are doing. Congratulations, Thomas, once more. Thank you
Thank
very
you.
much, Dr. Mahesh, and thank you everyone in 3211 for a wonderful hearing. Thank you very much.
Thank you very much, Dr. Ajay, for your sharing us your valuable words. Thank you very much for coming to our district.
Now the inaugural session is over. Now we will have the technical session. Let me invite Dr. Adonis Menon to take over as the moderator and lead the seminar.
Good evening, everyone.
Welcome, Dr. Adonis Menon. Welcome.
Thank you, Dr. Thomas. Good evening, everyone. I'm sure I'm
evening.
audible.
Yes.
Thank you. So respected Dr. Mahesh ji, Dr. Thomas, Dr. Harish, Ajay Umar sir, and everybody else. If I have missed out anybody, it's not by intent. It's not intentional. But I think it's great that you have decided to do a symposium on or a seminar on such an important topic. And I think as the previous speakers have alluded to, there's perhaps no better topic that would be relevant to all of us. As you're all getting older, this is a disease that sooner or later is going to catch all of us. But we live, I mean, it's not only just individual, it is also for people around us, our family, our friends, everybody or one or the other suffering from this disease. So it's not just for us, but also for everybody around us that we need to know a lot more about this disease. So I think it is a very, very relevant disease. And if you take this as a project for 10 or 20 years, I'm sure you will not be disappointed, because I don't think we will see the end of this disease during our lifetime, because that's the way things are going, as previous speakers have already alluded to. So what I will try and do is, in the next, I'll just give a quick introduction, and then we have got a wonderful panel of speakers. I know we are going to be challenged for time, largely because everybody has been given 10 minutes, and I'm sure each of our speakers are specialists in their field, and they probably can talk for hours and hours on the topic that's given. But I think it's trying to fit into the time allotted, and then perhaps take some questions and answer. I'm sure there'll be a lot of questions about this disease, because everybody knows about this disease. I think one of the biggest problems that we are seeing in Kerala is not the lack of understanding. Sometimes it's a question of wrong information and reaching wrong conclusions and making, unfortunately, wrong decisions. And I think that is something which we all should be very careful about. So it is important that we get the right information so that we can pass it on. It's just not doctors, not just nurses, not just medical professionals, but everybody else. So that is how we titled the seminar today. Let us just look at what the diabetes burden in India is. I think that it's very important for us to know that, so that we can know the magnitude of the problem we are dealing with. So the best data we have is something that was published about 2 years back. And as I've titled, it's a picture that's worth more than 1,000 words. So you can see that if you look straight away in that picture, what it is showing is that, more than 10.5% prevalence. Which are the states that have it? So this is a 1990 figure, and this is 2016 figure. Okay, 1990 versus 2016. And even in 1990, Kerala was leading. Tamil Nadu was just behind, not far behind. And what's happened in 2016? We have continued our progress, relentless progress. Now, there might be many reasons for this. We'll probably touch upon this. I'm sure over the next hour and a half, we'll be touching on many of the aspects of this. But just see the magnitude of the problem. This is the best data we have. So I think we have to trust that data. But what is showing is that not only that our prevalence was already high, but over the last, say, 20, 25 years or more, our prevalence has continued to steeply rise. So does that mean that it's only a disease of fairly developed states? Perhaps not. Why I'm saying that is, if you look at the rate of increase of this this prevalence, what we are seeing is it is actually the states that come under the kind of developing states, or where there is poverty and other things. Those states are the ones that have seen the highest increase in prevalence. Okay, so that just tells you that it's not a disease of affluent alone. So it's not because the Keralites are sedentary and eating more and all that. It's not just for us. It's a disease that every Indian is going to struggle with, because that is what this data is showing. So what are the major factors? At least from this study, what was clear was the major factor that they could see was the high BMI, that is the weight, the body weight seems to have correlated most with that. Of course, there were other risk factors that we know of, which you always talk about, but the weight control seems to be perhaps the biggest factor that we could find. So it's not as simple as just controlling your weight. There are so many other things that we have to get into. And our introductory speaker did talk about the need for the stress, something that we can't quantify and which is not there in this chart. So there are a number of factors that we haven't put in there, which are also reasons for the diabetes increase. Now, is this just a problem for us? Unfortunately not. If you look at all the developing developing countries, as well as developed countries, like you look at Europe, you look at North America, all the kind of countries that we talk about, everywhere there's been increase. So I think this is a global problem. This is perhaps the largest epidemic in human history. We are in the midst of a pandemic, and at the moment we are only talking about that. We're talking about COVID, day in, day out. And in between all this, we are actually in the midst of the largest epidemic in human history, which is going to perhaps span over 50 years or 100 years or probably even longer. We don't know. Are we doing enough? I don't think we are doing enough. Why do I say that? Largely because whatever we do, that's probably not enough in this scenario, because everybody is affected by it. Every country is affected. Every person is affected. So however much we can do, it will only add to the benefit of the society. So certainly this is a lifestyle disease, and each individual can contribute, whether that be a health professional, whether that be person without diabetes, how we can support our friends, family, as I've said earlier. So there is a huge, everybody should know the right information about this disease and should be able to pass on the right information. Many times it's just the wrong information that we pass on, as I said earlier. So that's one of the reasons why World IDF, which is the International Diabetes Federation, every year actually celebrates World Diabetes Day. And it's always on November 14th. And this couple of years, last 2 years, in fact, the theme was family and diabetes, which was perhaps a very, very important topic. And just to raise the awareness of that. And now it is, this year, it is diabetes nurses makes the difference. So, to take this theme forward, I would request Professor Molly Katie, who is principal of Amrita Nursing School. Sorry, madam, your slide has gone off, but she has got an illustrious career in nursing and in teaching. She spent quite a bit of time in UAE and then came back, and she has been a leader in the nursing education over the last 2 decades or so. And so we are very fortunate that she has agreed to speak to us about this particular topic of nurses and diabetes, or how nurses would make a difference to diabetes. Over to you, ma'am.
Thank you, Dr. Arun. Can you hear me?
Sorry, ma'am. I'll project the slides, or do you want to project the slides? Can I?
No, it's okay. Okay, please, you project it.
Okay, I will do that. So there's quite a lot of disturbance coming, isn't it? Is that only in my screen, or is everybody seeing it?
Yeah.
Somebody is having fun. That's fine. So it's all about fun as well, isn't it? Okay. So yes, that is Madam C. Okay, ma'am. Over to you.
Okay. Okay. Um, I hope everybody is well and keeping fine. Am I audible? I'm asking once
Yes,
again because there are
yes,
so
ma'am.
many things coming in the screen. That's what.
Yes, yes,
Okay.
ma'am. You're audible. You're audible.
Okay. Good evening, all of you, ladies and gentlemen. And at the outset, I would like to specially thank the organizers of this function, especially Dr. Harish Kumar and Dr. Arun K. Menon, who has invited me to share with you a few words on the World Diabetes theme. Nurse and diabetes. Nurses make the difference for diabetes. Next slide, please. WHO has declared 2020 as the International Year of the Nurse and Midwife. The purpose was to increase the global nursing workforce and to demonstrate nurses' critical role in global healthcare. So institutions like us, we all had, a great plan to celebrate various events and various programs during this year. But you know very well what COVID has done to us. But then I must say that, because of the COVID-19 pandemic, that itself has demonstrated the critical role of the nurses in global healthcare. So we need not organize any events or programs. People have understood it already. Okay, next one, please. Next slide, please. Okay. So what is the key message? I have only 5 minutes. So I'll just try to share maximum within this 5 minutes. The key message, you can see that nurses make a difference in diabetes. So there are two key aspects. One is the diabetes itself, and then nurses. So there are two questions in this. So why is that, nurses especially can make, a difference in diabetes? And why is that, they can do a difference more in the case of diabetes? These are two questions we will just analyze and see. Next slide, please. I think regarding diabetes, I need not talk much because Dr. Arun has already highlighted. And just I would like to say just one or two things. That, as he said, this is predicted to increase to 578 million by 2030. 1 in 2 adults with diabetes remain still undiagnosed. And 1 in 6 live births are affected by gestational diabetes mellitus. Next one, please. 1 in 5 people with diabetes are above 65 years old. This is very dangerous, especially during this COVID season. And diabetes has caused so far 4.2 million deaths. And, it causes a great economic loss. Next slide, please. Now, related to nurses, we need to know that, nurses are the large sector of, health providers. They account for around, 59% of the health professionals. Currently, the nursing workforce is 27.9 million, but still there is a shortage of 5.9 million. So we need to have, a growth of about, 8% per year of nursing workforce if we have to meet the needs of the people. Next one, please. Next slide, please. So diabetes, what is that something special about it? We all know that it's a chronic multi-system disease, and more about that, there are eminent people to speak on that. But we need to understand that it is a whole life disease where the patient has to be aware. The family members need to be aware, and there need to be adequate number of people to support, to teach the patient. So that is the significance of diabetes as a devastating illness. Next slide, please. So diabetes self-management education is the most important one. We want, the diabetic clients to be actively participating in their own care wherever it is possible. Of course, if not possible, at least one family member is to be empowered. They may encounter many barriers. Now, these barriers are plenty. There are many studies related to that. Maybe the patient feels, inadequacy. As Dr. Arun said rightly, there may be misconceptions. or there may be lifestyle changes, issues. So all these require, constant, continuous psychological support. Who is going to do that? Is it the doctors? Because they are very busy with many other issues. And nurses are the people who are with the patients 24 hours in the hospitals and in the community also. There are many nurses. I have been a teacher of junior public health nurses too. And nurses can help, actually the patients teach many things to prevent complications like hyperglycemia, which is important because even now patients think that, hyperglycemia is more important than hypoglycemia. And even to tackle the risk factors that may lead to diabetes mellitus, for example, obesity. So nurses can do a wonderful job, but there is some problem. So they need to be empowered with that. Next slide, please. Next one, please. Okay, what can be done? So ensure quality of nursing education. So the question is, the present nursing education, does it help in, dealing with the latest things about diabetes? I must say that, many nursing studies have shown, many nursing students and even the nurses, they say that, it is not updated. So it has to be included in the curriculum. We are getting it revised again. Once again, the curriculum is getting revised. Invest in the recruitment and retention of the nurses. Nurses need to be retained. Where are our good nurses? Most of the good nurses are abroad. Why? Do you think it's because of only because of the salary? No. I don't believe that. It's because of a good working environment. If they are paid well and trained well, definitely we can retain many of these nurses. Need for more education and funding to equip nurses. Those nurses who are employed already, what can we do about it? We need to give them in-service education. See, hospitals like Amrita, we do have, a 2 days diabetic care in-service education program. This is given to all nurses, batches by batches. I encourage my teachers also to take that. I encourage my students to do that. They get certificate. So this is to be done. Recognize the advanced role of nurses in diabetic care. All these 4 decades of nursing almost, I'm going to complete as such. I have always wondered, how can the policy makers and administrators and even the senior doctors can expect, a general nurse or a general education-based, BSc nursing graduate to work with, an endocrinologist or a diabetologist who is working in that particular area for the last, 15 years or 20 years. So we expect the nurse to know everything. So definitely we need to think of, advanced roles of the nurses. There has to be, roles like advanced caregivers, diabetic educators, along with, diabetologists, who will be really knowing what they are expected to do. Now, the next one is maximize the contribution of nurses in primary care. Because looking at the alarming increase, in the number of, diabetes cases, we can understand that we will not be able to manage it in the secondary level or a tertiary care hospitals, tertiary care centers. So what is to be done? This has to be incorporated with the primary care. So in this connection, I just would like to say just one word about, one of the studies I have gone through. This is a study published in 2019, Diabetes Care in Public Health Facilities in India, using a mixed method study by Jaya Prasad Tripathi. And this was conducted in 6 districts in 3 states, it means 30 centers, 5 tertiary, 8 secondary, and 17 primary health facilities. They were visited. And what was the result? The result is very disgusting, I'll say. Patients' clinical records were not maintained in all these 30 facilities. None of them provided HbA1c estimation, lipid exam, or foot care. Lifestyle modifications were, of course, supported by only a few tertiary facilities. And patients had to visit the tertiary facilities for drugs and routine follow-up. So this is the situation in India. So definitely nurses have to be empowered if we need to cover, masses with diabetes. Next slide, please. So nurses can make a difference. Nurses can change the lives through the quality of care and through educating the masses, and of course through providing emotional support when the patients are in trouble. So, and for that, they need to be empowered. Again, there are, so many studies, but mostly Western studies. I'll just quote one: effect of a nurse-led diabetes self-management education program on glycosylated hemoglobin among adults with type 2 diabetes mellitus. This was by Asami et al. 2018. It was an RCT on 142 patients, and they followed up, the patients for a period of 12 weeks. They have checked it, and 24 weeks again they checked it, and they found that there is a significant improvement in HbA1c. Not only that, also improvement in BP, body weight, and diabetes self-management behaviors. So that means nurses can change the lives provided they are empowered and retained. That's all I want to say. Thank you very much. Thank you very much.
Thank you, ma'am, for an excellent inaugural address in terms of setting the stage for this seminar. So, Jojo, we are moving on. Are we okay? Jojo, do you want to? Because there's been quite a bit of disturbance.
You wait for someone, and there are some kind of a problem happening in the meeting. I do not know. We'll just do. So far, it is not disturbed, but still you can continue, doctor. If at all anything happens, I'll let you know.
Certainly. We'll carry on. We'll see.
I'm taking care of it. I'm removing all the problems right now. Let me
Perfect.
see. If at all
Perfect.
Okay, thank you, Dr. Arun. Thank you.
Thank you, Professor Moli, for the wonderful lecture. So we will move forward. I think the next topic that we'll discuss this evening is about the screening for diabetes and its complications. I think we have got a few topics which we thought are the most important to discuss today. Of course, we can't complete everything, and we don't expect to do that. But at the end of it, we have allotted 20 minutes for discussion. So if people have genuine questions, please post that on the chat box. It might be easier that way, because if you all start to talk, it might be more difficult. But again, it would be good if we can use the chat box as a medium to communicate with the speakers. We'll take the questions in the end anyway. So to take this topic forward, I request Dr. Mohan Shenoy, who is a student of mine, and he's one of those promising budding endocrinologists who has who passed out from Amrita Institute a few years back, and he has already made a name for himself in endocrinology. A very vibrant speaker and a very helpful colleague. He's currently working as an endocrinologist, consultant endocrinologist, and assistant professor in Sri Gokula Medical College, Trivandrum. He's got various publications and write-ups in his name. So he's one for the future, I'm sure, and that's why Harish has requested him to join us this evening. So over to you, Mohan.
Yes, sir. Good evening, everybody. Can I share the screen, sir?
Yes.
You have to stop sharing, sir.
Sorry. Yeah.
Yes.
Thank you.
Yes. So good evening, everybody. I thank you, the Rotary International 2211, for giving me opportunity. So as I go into my, can you see the screen now?
Yes, we can.
Yes, sir.
Yes. I'm very glad that I was given this opportunity, because this topic is very dear to me. The topic for me, I will check my time limit of 10 minutes. It will be regarding screening for diabetes and its complications. So as you know, the diabetes and high blood pressure are two silent killers, and these are two metabolic problems that we have to control before they start controlling us. Because the WHO has also recognized that the risk factors for type 2 diabetes are the following: unhealthy diet, as you know, then physical inactivity. And they also suggest that all of us have to eat healthy.
Dr. Mohan, I'll just interrupt you, because you have network issue going on. Your bandwidth is very low. I'm switching off your video. We can continue after that. Thank you.
Okay. Yeah. So the key actions for everyone would be to eat healthy, be active, avoid the physical gain, weight gain, and check the blood glucose level whenever you have doubt, and follow the medical advice. So this is what the mantras what has been suggested by WHO for regarding this. And we in India are also doing the same. We are screening the population at every level which possible, and in any possible manner we are giving awareness to the patient as well, and our caregivers also are given training. So the best possibility is to screen the population. As you know, we have a large population burden of diabetes in India, and in Kerala we have got diabetes load as well. So screening test for diabetes has to be very simple and reliable as well. And when you identify the target population which needs to be further tested, then we can advise them and support them. And of course, treatment is very important. So fasting glucose, HbA1c, and postprandial glucose are the three dimensions that we are called glycemic triad. So random blood glucose plus classical symptoms of hyperglycemia are the ones which we are testing when the glucose value is more than 200. So random glucose means any time of the day without need for time in the last meal. Symptoms of random glucose can be polyuria, polydipsia, or unexplained weight loss. By polyuria, we mean increased urine output. By polydipsia, we mean increased thirst. And unexplained weight loss means there is no intention to do weight loss, but still the weight gets lost by unintentional purpose. The fasting glucose values have to be kept within the range between less than 100. So if it is between 100 and 126, we call it as impaired fasting glucose. And in diabetes, we term it when it is more than 126. This is from the WHO. And comments would be there should be no caloric intake for the last 8 hours. 2-hour postprandial glucose values during an oral glucose tolerance test is the term for impaired glucose tolerance. So for this, we mean that we have giving a 75-gram anhydrous glucose dissolved in water and checking the glucose values after the period of 2 hours. The one which we are usually doing is the postprandial glucose without doing the glucose tolerance test. The other test which we are all popular, and already Dr. Mahesh has mentioned it very clearly, it's called HbA1c. It is the one which is used very gold standard days because it's a measure of the previous 3 months glucose control. It should be done in an NGSP certified laboratory, and the target level should be kept less than 7%, though the American guidelines mentioned to be stricter than that to 6.5, it is less than that. So we should keep the patient under the control of the glucose levels. So we have a standardization by NGSP with the lab level, because not every lab is supposed to do this test. So only the lab which is standardized do this test as per the DCCT and UKPDS studies. This is the one we are used to be relied upon. So what is HbA1c? HbA1c is also called glycated hemoglobin. It is a surrogate marker for the appearance and progression of complications of diabetes. As this diagram clearly shows you, the red blood cells or RBCs in the body are having glucose moiety in the system binded to hemoglobin. And when hemoglobin A1c is measured more than 7%, ideally, we can see that diabetes is already established. And it's indicated for diabetes control and as well as the glycemic load. So the glycemic fluctuations of the patient, the glucose control fluctuation is the one we have to address by controlling the HbA1c values. So what are the complications of diabetes? To simplify the complication, this diagram will very clearly help you. The main complications I have shown as microvascular and macrovascular. To simplify it for the general public, we are putting it in a diagram. On the left side, you can see the peripheral neuropathy that affects the neurons. On the higher side, it's the stroke or the cerebrovascular accident. Then it is called the common term called heart attack or called cardiovascular disease. There is also a peripheral vascular disease called peripheral arterial disease, which can manifest by severe pain in the legs. There is also a possibility of patient developing diabetic retinopathy and is very painless and gradually progressive. And screening for all this is not possible in a busy clinic. That is why we have to have the screening charts and identify the severity of symptoms, whether the person really deserves for the treatment as and when the treatment progresses. Towards the end spectrum, we are also mentioning that glaucoma, cataract, diabetic foot infections, as well as diabetic nephropathy affecting the kidneys. So as we have simply showed you, it is not just about glucose management. We have to counsel the patient, understand in a graphical manner the main pathophysiology between the The classical phenotype is called type 2 diabetes is called insulin resistance. By this we mean insufficient glucose uptake into the cells after the meal. It can be either because of malfunctioning insulin or insulin receptor, or it can be because of the overflow with glucose. Either way, the glucose cannot enter the body cells and builds up in the bloodstream, and you can see that over the time, constantly high glucose levels can damage the blood vessels and the major organs. So you imagine that the load is also high, the duration is also high. So people with living with diabetes definitely have to control the glucose level before the glucose levels start dictating the terms to them. So my major factor for screening is also family history of diabetes, because this question mostly people will not know when they are asked in the question. So we should ask them whether they know or not, whether they can tell us the next visit at least. So this is the picture again showing you that type 1 diabetes and type 2 diabetes are very distinctly mentioning the role of autoimmune disease, genetic etiology, immune dysregulation is also mentioned in type 1 diabetes. On the right side, I'm showing you a pedigree chart. This is the way in which a family history can be plotted. So the rectangle shows the male and the circle shows the female. Affected person we mark in a black color. So this shows that the person in question can definitely have a long history in the family, and definitely this is the one of the easiest way in which we can plot in the case sheet when the patient is coming to you on the clinic. So I would say International also suggest to develop a diabetes wallet card. Just like we have got an ATM card or even a Switch 5 card, we can have some similar card for the patient who's having a diabetes, because this is very common that patient doesn't know, the relatives don't know often. So patient can come in a very situation without the patient being given proper management. So this is the way model which the NHS is doing, the UK are doing. On the right side, we can see the American Diabetic Association suggesting a diabetes risk test. This is one of the ways in which we identify the at-risk population. There are 7 questions being mentioned. One of the main question is the age. The second one would be gender. The third one, when you are a woman, the risk of diabetes being there in the gestation, there in the pregnancy, or even the family history, the father, mother, sister, or the brother with diabetes. So ultimately, the activity is also scored and the weight gain is also. This is a very simple score which has been foolproof and measured in the ADA recommendations as well. So I mentioned about the early onset type 2 diabetes. Any type 2 diabetes in strong list of diabetes, with the right side you are seeing a picture showing the neck, showing the back. And also
Dr. Dr. Mohan is having a network issue. I think we are not hearing him.
Yes.
Dr. Arun, can you do something? Can you talk to him, or can he join from other device, or we'll switch off the next person so that he can improve his bandwidth?
Yeah, fully muted.
I think, yeah, let me just speak to Mohan and find out what's happening.
Yeah. His bandwidth is very low, Dr. Arun.
I can see that, yeah. And you switched off the video, still it's not good, doesn't it?
Even still with that, he cannot manage it.
Okay, let me just give him a ring and then.
Fine.
Almost, the talk is almost over, I think. Yeah. Almost.
I've logged the meeting. So far, I don't think any more problem will come up. So we can continue with the meeting.
Patan, see waiting room. Somebody is waiting.
No, I'm scrutinizing. I'm screening it and only admitting them, because there is no intruders inside. So I've kept the meeting locked for some time.
So Dr. Mohan is saying that he's trying to enter. We'll give him a few, but 20 seconds just to complete his talk.
Yeah, he's entering. He's asking for entering again.
Yes, we're giving him the.
Yeah.
Hello, Mohan. Are you there?
He entered the meeting, but his audio is not there. Even the video is not switched on.
Yeah, let me just see. I think he's calling me again. Let me just. Hello, is Mohan there? If not, can we just move on? I think he's having some problems joining. He has joined, but I think his audio is not coming on. So not sure whether this is also part of the hacking that's going on. Mohan?
May not be, because he do have a network bandwidth strength problem.
Okay. So you think that's the reason? That's
Yeah,
right.
that's the reason. Nothing of that sort. Now we can go to the next Dr.
Okay.
Anjan, I guess.
Yeah, and Mohan is asking to enter the meeting. Yeah, he's asking.
I think I've entered.
If
Yeah,
has
better.
entered, yeah.
Yeah, he is there.
Somebody has muted me. Yeah.
No,
Sir, I think, Arun sir, can you run it from there, sir? I have sent you the slides. Hello, can you hear me?
Dr. Arun, can you just share the PowerPoint presentation which Dr. Mohan had sent you? Dr. Arun, you are muted.
Okay,
Arun is
no problem.
muted.
I am trying it.
Yeah.
Yeah. No problem. I'm doing it. Yes. I will just run through my last part of the slides.
Okay,
No problem.
please.
So we were here. Yeah. We just finished it up. So as I mentioned previously, that HbA1c is the main gold standard. So reducing HbA1c impacts the long-term complication progression. So every 1% drop of HbA1c achievement.
Your slides are not visible, Doctor. Your slides are not visible.
Mohan, just try once more. If
No.
not, I think we will move on. I think there is some issue there. I think we might waste quite a bit of time otherwise.
I think my end, my network is very good. I don't know.
Yeah, we can't. Your voice is breaking all the time, so I think it doesn't look as if it's getting better. So hopefully we can, if there is time, we can go back to Mohan in the end. So with that,
last part, sir.
I think it's a signal strength problem. I think.
Dr. Arun, he has to change the device and then join. Otherwise, with this device, he may not be able to continue. That is the experience I have. Now, I think we'll go to the next part.
Yeah. I have finished the slides. This is the last slide.
Last slide. Yeah. Last.
Okay.
Yeah.
Hello, Mohan. Okay, does it say, is Mohan there or is he?
No, he's not in the meeting now.
Okay, fine. I think we should move on. I think we should, otherwise we'll waste quite a bit of time. So just give me a second. So the next speaker, can you see my screen at all?
No, we are seeing you, Doctor. We are seeing you, Doctor.
Yeah, you can't see the screen, isn't it? Yeah, okay, fine. Let me just.
You can share the screen. Biodata of Anjana. Okay.
You can't see. Okay, just give me a second. Are you seeing my screen now?
No, Dr. Arun, we are seeing you and Dr. Anjana.
Okay, I think we'll go ahead. I wouldn't waste time on the screen either. So let me just welcome Dr. Anjana Mohan, who is a diabetologist from Chennai Institute. As you know, this Dr. Mohan's Diabetes Center. She's the managing director there now. She's one of those young and budding diabetologists who has already done great amount of work in diabetes and related complications. She's a proper researcher who has published significantly. So it's really, we are fortunate to hear from Anjana this evening. Over to you, Anjana.
Thank you very much, Dr. Arun. It's very nice to be here. And I'd like to especially thank Dr. Harish for giving me this opportunity, as well as the Rotary Club. So I think what you've asked me to speak about today is diet and physical activity in diabetes. So I'm just going to share my screen now. If you just give me a minute. Can you see my screen?
Yeah, doctor. Yeah, doctor.
Okay, right. So I'm going to be talking about physical activity and diet in diabetes. And I come from the Dr. Mohan's Diabetes Specialty Center, Chennai. So let's start with physical activity. Now, the first thing I always talk about is the difference between physical activity and exercise. A lot of people get this confused. So they think this is synonymous with each other, but there's actually a little bit of difference between the two. Now, physical activity is defined as any body movement produced by skeletal muscles that results in energy expenditure beyond resting, which means lying down. So any movement of any sort would be counted as physical activity. Then what is exercise? Exercise is a type of physical activity that is planned, structured, repetitive, and purposeful, usually aimed at improving health or maintaining fitness. So it's a type of physical activity. And why this is important is because in a nation like India, the concept of exercise hasn't caught on to most parts of the country. You may find pockets of urban, metropolitan cities or little educated states understanding this, but by and large, we have to talk about physical activity because that is what links to health, especially like NCDs. So now when we look at the components of exercise, what are the different types of components of exercise? The first is aerobic activity. Aerobic simply means utilization of oxygen. So anything that makes you use oxygen and pant, like running, cycling, walking, jogging, swimming, dancing, whatever that you know as exercise would be considered as aerobic activity. The second one is resistance training or muscle strength in a country that has a large sarcopenic population, which means we have less muscle strength, less bone mass as a nation. This is a very, very important component of exercise. And the third is flexibility, which allows you to do the other two components without any problem. Now, what are the benefits of exercise in diabetes? At every stage in diabetes, exercise has benefits. So before diabetes, if you are someone at high risk, and we saw there was a risk calculator that they showed earlier, the doctor showed in the previous slide. So if you're someone with high risk, you have pre-diabetes, your family history, you're obese, then exercise helps in prevention. It helps in maintaining your blood glucose levels if you're someone with diabetes. It helps in prevention of complications like eye disease, heart disease, etc. if you're someone again with diabetes, and there are many additional benefits. Now, it also brings down your total cholesterol and your bad cholesterol or LDL cholesterol. It improves your HDL or good cholesterol, brings down triglycerides. It brings down your blood pressure, your body weight, your body fat, improves muscle mass, alleviates stress. It strengthens bones, prevents osteoporosis or weakening of the bone, especially related to age. It improves quality of life, sense of well-being, improves your mental health, and reduces your risk of dying prematurely. So you can see it is a complete holistic head-to-toe kind of thing. It's not just diabetes, but it has everything. It has multiple benefits when you talk about physical activity or exercise. Now, why is it that when I told you all about exercise so far and why it's important? But in a country like India, and I'm going to show you data from the ICMR India Diabetes Study, or INDIAB study for short. Now, this is a national study on diabetes being done in every single state of the country. So state by state by state, like 10 years it's going on. And it's a cross-sectional door-to-door survey. We had Professor Jabbar, who was in charge, who was a PI for Kerala. So that has also been completed. So what we're doing here is looking at the prevalence of diabetes and associated risk factors, including diet and physical activity. Now, if you look at the percentage of inactive subjects in the population, on the x-axis, you have all the states that we have been studying, and you have the percentage inactivity. So shown here, the red bars are urban areas, and the green bars are rural areas. So look at this. You'll see state by state by state that the inactivity levels are so high. Not only in the urban population, some states have reached 80% inactivity, but also the rural population. This is the 50% level. 1 in 2 people in rural areas in most states of this country are physically inactive. What about males and females? Females are way more inactive than men. As you can see here, the inactivity levels are much higher. So what then happens? Well, you get diabetes. So shown here, the purple are the active guys. This is your risk of diabetes. Can you see as the activity level kind of decreases, as you go from very active to inactive, your trend of getting diabetes becomes much higher. So the less active you are, the more diabetes and all kinds of diseases you start getting. So what are the exercise recommendations now? We follow what is called the FIT principle. Now F stands for frequency. Now all the guidelines talk about doing 150 minutes of moderate to vigorous intensity activity per week. So what is that? That's actually 30 minutes 5 times a week. That's what it translates to. But what actually happens is that the type of activity, the intensity of the activity is never enough. And because of this, generally, as a guideline, we tell people to walk for 60 minutes on most days, 7 days a week, will start getting you the metabolic benefits. So as per guideline, you'll see that at least 5 days a week, intensity at least moderate. What does this mean? This means that if you walk for 1 hour, you should have covered a distance of 5 to 6 kilometers. Now, most people don't do this. In 1 hour, they reach like 2.5, maybe 3 kilometers. It's half than what is recommended. You have to walk at a speed where in 60 minutes, you do 5 to 6 kilometers. Only then your speed is correct. Type is aerobic plus resistance. I've explained this to you. And 30 to 45 minutes. For India, it's better to say 60 minutes at a stretch. So in younger children, what is the recommendation? It's straight away 60 minutes of MBPA, that is moderate to vigorous intensity activity daily. So 67 days a week for children. We have data to show that our children do not even meet half of these recommendations. And it's much worse in girls, especially adolescent girls, compared to boys. So they just don't meet any of the recommendations. It has to be aerobic, and the more vigorous the activity, the better for the child or the adolescent. So these are the recommendations. It says 150 minutes MBPA, that is moderate to vigorous intensity activity, and resistance training, which is muscle strengthening, at least 3 times a week is to be encouraged. So both you must do. You must do your walking, plus you must do a little bit of additional strength in addition 2 to 3 times per week. So what about for people who are in the elderly age group, more than 65 years? Again, here age is only a number. If the person is healthy and otherwise okay, the recommendation holds. It's the same for all adults, including the elderly. Now, if someone has diabetes, has related eye problem or foot problem or something like that, then we say do as much as possible. So at least 10 minutes at a stretch, we ask them to do. So maybe they can do it twice or thrice as bouts of 10 minutes. But as much as possible, whatever they can do, they should try and do in the elderly age groups. Important points to note, our exercise regimens are highly individualized. If you're someone with diabetes, you must always consult your physician before starting the exercise regimen. Exercises are to be graded, especially when you do strength training. You cannot do the same thing every day. You must keep increasing the intensity. Warm up and stretches are very, very important. You suddenly put your body through an intense workout, you'll sprain something, so you must do it the proper way. Proper footwear, especially if you have diabetes and foot-related problems. I cannot overemphasize the need to have the correct footwear. In our country, dehydration is a problem, especially if you're running in extreme heat or you're walking in extreme heat. So have water with you. And of course, if you're above 50, you must consult a physician before you start an exercise program. So that completes the kind of recommendations and physical activity part. Now the dietary part, and in India, this is always a very, very popular. Everyone wants to know what we can eat. So this is a survey of what Indians eat, and this is just from supermarkets in Chennai city. 150 supermarkets were surveyed in Chennai, and this is what we found. 80% of everything that is even stored in the supermarkets is starch and sugary foods. 5% were health foods, and other frozen oils, etc., were 15%. So just about 80% of everything was unhealthy food, even available to you. So the first and most important thing, of course, would be because 70% of everything the Indian eats is carbohydrate. And if you live in South India, about 95% of that is rice. So everything that we eat has some kind of rice combination in it, whether it's rice itself or idli or dosha, whatever it is, it has a rice combination in it. So this is what we call the glycemic index. Now, what is this? This is the ability of a food to raise your blood glucose. It's as simple as that. If you take sugar to be on a scale of 100, then how much does each of your food substances raise blood glucose? And that is what is called the glycemic index of a food. For rice, it's anywhere between 72 to 77, 79, depending on the type of rice that you have. And there are many, many factors which influence your glycemic index. This is the nature of the starch, the particle size. So oftentimes, patients come to me and ask, doctor, I'm eating chapati. Why is my sugar not under control? Okay. So by nature of grain, the chapati is supposed to be made from whole grain, so which is supposed to be healthy. However, today, the problem that we have is that all of the flour that we get is highly refined, chakki fresh atta. So, and because of that problem, the particle size becomes very small and the glycemic index is high. So it is equivalent to rice, the amount it is able to raise your blood glucose level. So particle size is important, the cooking method is important, the degree of processing is also very important. So all of these things determine what is the glycemic index of your food. So this is the rice that I was talking about. Sona Masuri, we have Ponni, Shruti Kolam, and other types of rice. So oftentimes now people ask about Kerala red rice. Is that different? Is it better? The glycemic index is slightly lower, but it's still in the high GI category. So, and we'll talk about brown rice next. So all of this, if you look at it, it's 72, 77, it's all quite high. It has to be below 50 for it to be a lower GI product. All of these are high GI. So this is a study that is called the PURE study. It came out very recently in the papers, where 21 countries, we studied diabetes and rice intake. So what we found, so you have all of China, you have the rest of the world, you have UK, US, you have Canada, all of these countries here. And what we looked at, what is the hazards or the risk of developing diabetes with rice intake? Now you can see that the South Asia, this is the null line. If it touches this, then it's not significant. Look at South Asia. It's specifically on so the highest risk, and India is the biggest contributor to this. So in India and other South Asian countries, you see that the rice intake is, it's not just the rice itself, but the quantity of rice that matters. Whereas China is a rice eating nation, look at it, there's no risk. The rest of the world also a little bit. So overall, we are being driven by the South Asian kind of phenotype. So in addition, you add the physical inactivity, it doubles the risk. So you eat a lot of rice, plus you don't move enough, so your risk of diabetes is higher. Whereas even if you eat a certain quantity of rice, if your daily life makes you very active, then the risk of diabetes comes down. So then we ask, okay, so you were saying that white rice is bad, it's high in GI, it's increasing your risk for diabetes. What do we do? Then we talk about brown rice. So this is a study we did with Harvard, where we looked at trying to replace all of the white rice with brown rice to see whether it had any effect on diabetes. And this is what we found. So the blue lines, these are data from a continuous glucose monitor, which means that every 5 minutes, your blood glucose is being measured by an instrument that is put on your body. So once you do that over a period of a few days, so here you can see a single day that is being shown, but over a few days, like a week, they will be able to show you what is your glycemic response to every meal that you're having. So look at this person, breakfast, lunch, dinner. And you can see the huge spikes that are happening with the white rice intake. Now, if you change that to brown rice, the glycemic index comes down, or the glycemic response comes down. On top of that, if you add some legumes like dal or something like that, then it comes down even further. So the kind of brown rice with legume is the lowest in the glycemic responses. So what did we show now? Okay, white rice is bad. It's okay to substitute brown rice with white rice. So we started telling people, you know what, try taking brown rice. It's good for you. It's healthy, etc. But then there was a huge problem. Okay, people didn't like brown rice. They didn't like the way it looked. They didn't like the way it cooked. They didn't like the way it tasted. They didn't like the way it digested. Okay, they refused to accept it. And they didn't want brown rice. It's too sticky. It's too this, that, all kinds of complaints about brown rice. They don't want to take it. So the kind of acceptance that we got with brown rice, although it is very healthy, people were not willing to take brown rice. So that is the problem we started having. And thus we today know that there is definitely a space for healthy white rice related products. And that is what the population is overall looking for. Now, what about millets? So everyone's talking about millets. Is it healthy? We are all changing to millets. Is it helping us? This is a stereo zoom microscope from our research foundation, in which these are the kind of small millets. So you have barnyard, foxtail, kodo, little, and proso here. And look at the unpolished actual millets that we have on the first panel. Look at the color of those millets. Look at those millets in general. And then look at the same millets that we bought from shops. So the market samples of these millets, you'll notice that definitely there's a color change. Okay, so they're looking whiter, which means that all of their protective coats are being removed. They're being polished. So the minute you polish it, it gets refined. That's number one. Number two, you'll see that all of these top panel ones have this little black dot that's called as germ. If you look at it, there's a black dot in most of that. Now, if you look at the second panel, you'll see that it's looking like a kidney bean. Everywhere the black dot is gone. Can you see? It's very, very clearly been pulled out. So that is the nutritious part of the grain. The rest of it is only starch. So with the process of polishing, this gets pulled out and all the nutrition in the millet is lost. Its fiber is lost. Its entire nutritious value is gone. And what is left is a refined starch. Thus, if you look at a continuous glucose monitor, you have a 5-day here, you will see that with a white rice, you have the, let's say the red line, which is white rice. Now look at ragi. It is almost exactly the same. Sometimes it's even higher than the white rice. And this is not the fault of the grain. It is the fault of the refining or the type of grain that is available to you in the market. And thus we found that we had a similar glycemic response with millet, almost as high as white rice. And this was the problem we are facing. Hence, there's a need to develop whole grain healthy flour. So the grains are good. How we are consuming it is the problem. Let's go on to nuts and diabetes. Coming from Kerala, the Cashew Council of India approached us and asked us whether we were able to show whether cashew nut was good. The minute you eat cashew nut, people think, oh, I'll gain weight. That's the first thing that people have thought about. So we tried to do, this is a randomized control trial that was funded by the Cashew Council of India, which looked at whether there was any difference in blood glucose level, blood pressure, etc., when you consume cashew. So what we did is we gave people with diabetes a cashew, a handful, 30 grams of cashew, which is in its raw form, whole cashew, raw form, not fried, not salted. We gave that to them and we saw there was no change in blood glucose level, but we found that the systolic blood pressure kind of came down. So did the diastolic. So there was a little bit decrease in the blood pressure. There was an increase in HDL, and this is explainable because the nut itself does have a kind of profile that is good, increases your good cholesterol. So this is the one, the oleic acid kind of goes up, the MUFA kind of goes up, and this is a beneficial change. So the conclusion from this study was that 1 handful of raw cashew nut a day was healthy, was able to increase your good cholesterol and blood pressure. It had no effect on blood glucose. It had no effect on weight. So weight did not go up for the entire period of the study. Fruits and vegetables, and that is the last part of my talk. So we all know that fruits and vegetables are good for us. But unfortunately, if you look at the country per se, and this is again data from many states in the country in the INDIET study, we have the recommendation that says, the World Health Organization says that you have to take 5 servings of fruits and vegetables per day. What is the national average? It is 2.4. In urban areas, 2.6. In rural areas, 2.3. Everywhere you go across, this is the fruit and vegetable consumption. That too, if you ask them, what is the fruit that you consume? It will be banana. Okay. And what is the vegetable you consume? Potato. Super. So not only you don't have enough of it, what you're taking is completely unhealthy. So, and then they'll ask, why is diabetes increasing and what's happening? The entire kind of fruit and vegetable concept is wrong in terms of the consumption. So how many people actually meet the recommended 5 servings per day? National average is 4.8% people eat 5 fruits and vegetables. So shameful to even talk about it. It's better in the urban areas, little bad in the rural areas. So how do you now put all this together, and what is a healthy diet? Quite simply, use the plate concept. If this is your plate, divide into half. Half of it should be fruit and vegetable and not potato and banana. It should be green leafy vegetable. Half the plate. You fill it with every color you like, red and yellow and green and whatever you want you put in on the one side. The other side you divide into 2. In one side you put your protein, whatever you want, egg, milk, vegetable protein, pulses, dal, whatever is 1/4. And only 1/4 should be carbohydrate. So your chapati, your rice, your whatever, pasta, whatever you want to take is 1/4. If you keep following this concept, then you are completely balanced in your diet. So I'd like to conclude by saying, in terms of physical activity, levels are really low in the country. The recommendation is that you do at least 150 minutes of MVPA, which is moderate to vigorous physical activity per week, and follow the FIT principle. For diet, decrease the carb consumption. We're at 70% now of carb. Bring it at least to 60% in the diet. Decrease that carbohydrate. What will you replace it with? Replace with protein. Protein intake is really low, and you increase the fruit and vegetable consumption. A handful of nuts per day is beneficial. I showed you about cashew nuts. You can also take almonds or pista or any of the other walnuts are healthy, hazelnuts are healthy. So a mixture of nuts every day, 1 handful is healthy. And those are the ways you try and decrease your MCD risk. Thank you.
Thank you, Dr. Anjana. So that is a great talk. And I'm sure this is the talk that everybody would want to ask questions on. I understand you have to leave very soon, is it? So you would like to take some questions up front. So shall we just give about 5 minutes or so? I mean, it's 6:20 now, maybe up to 6:25.
Yes.
That's okay. So if there are any burning questions, if people can come forward and ask the questions, that would be wonderful.
Dr. Arun, I have just copy-pasted a question from Mr. Pradeep Kumar. You can just check your chat box.
Okay.
I call Pradeep to answer.
Okay. So that is, so is this question, so please differentiate the metabolic effects of various carbohydrate derivatives, such as fructose, sucrose, etc., and the fruits which may be consumed by diabetic patients, indicating the best time, optimum quantity, etc. So that is question from Pradeep Kumar. So,
okay.
Yeah.
So thank you, Mr. Pradeep Kumar. For a diabetic, there are certain fruits that are allowed, and that will include, that is only if your A1C, your HbA1c, which is your 3-month control, if it is below 7, then we do allow fruits on, say, 3 to 4 times a week. Every time you have, it's 1 portion. For example, 1 apple is 1 portion, 1 guava is 1 portion, 1 cup of papaya or something is 1 portion. So that is the 1 serving that is allowed. You can take apple, guava, papaya, and all the citrus fruits. For example, your satukudi, orange, amla, all of these are allowed fruits. Now, having said that, there are, so glucose, fructose, and all doesn't matter to a lay person. Ultimately, everything gets converted into glucose in the body. So it doesn't really matter as far as you are concerned in your consumption. So fruits, if your sugar is well controlled, these allowed fruits you can take. Something that's very sweet, for example, your mango, sapota, grapes, these are all high in sugar. It will increase the sugar quite fast. So those are avoidable unless there are some people whose A1Cs are 6, 5, in which case those are also sometimes all right. But generally, we do not allow those kinds of fruits.
Thank you, Anjana. So I think there is one other question. Somebody has asked, what about fats? What is the reason for PPBS lower than fasting blood sugar?
Okay, let's do fats first. So fats is, I didn't talk about fats specifically for want of time, but everything you eat contains some kind of fat, especially if it's a cooked food. So your total fat consumption must be less than 30% of everything that you eat, of which saturated fat should be less than 10%. Now, what does that mean to a layman? It just means that you take healthy fat, something that's called as MUFA. Now, this is what you get in your nuts. So your nuts are a good source of fat, and those good fats are allowed. Your saturated fats are things like samosa, anything that's fried in oil, your chicken fry, your fish fry. All these things give you all the very, very yummy, oily stuff is all this saturated kind of fat, which should not be more than 10%. So that's about fats. What was the other question?
So that is slightly unrelated, but what is the reason for a lower PPBS than an FBS?
In a diabetic or in a normal person? In a diabetic,
right? Yeah.
Yeah, for both. So in a diabetic, it probably means that a morning dose of insulin or thing is a bit too much and requires to be brought down. In a non-diabetic person, it could be an early sign of pre-diabetes. So when you have a PP, generally you don't look at the postprandial. Actually, there is a misnomer. You look at what is called as a post-glucose. So after you give a 75-gram glucose load, you check, that's a different thing. You're not supposed to be looking at the postprandial in a non-diabetic individual. But if you do look at it and it is lower, then it generally indicates it could be a pre-diabetic condition. You will need to do a GTT to see, which is an oral glucose tolerance test, to see where you are in the diabetes spectrum.
Anjana, one more question is jaggery.
Exactly. So there are a couple of good questions coming up. One is honey in moderate quantity good instead of sugar? And the second is jaggery safer than white sugar?
So there's a lot of talk about whether honey is good, palm sugar is good, jaggery is good. They're all kind of related questions. They all, like I was telling before, there is no evidence to say one form of this sugar is better than the other. So when you look at white sugar, taking honey instead of white sugar for a diabetic will still increase your GI. Okay, so if you ask me whether an artificial sweetener can be used instead of sugar of any form, I would say yes, in a diabetic. If you need the sweet taste, then you use a sweetener, that's fine. But adding honey, jaggery, everything will increase your sugar. So we do not have today enough evidence to say that using palm sugar or jaggery or honey or any of those is good for your diabetes control.
That's great. So I think those are the questions.
One more for the layman. Most of the people are asking about jackfruit. Jackfruit can be taken or not.
So there is a person who is selling jackfruit claims that he's curing diabetes, no?
Yeah.
So unfortunately, we don't have enough evidence to talk about jackfruit curing diabetes or controlling sugar. Or it is like saying that there are lots of people saying a lot of things, but there's not enough evidence to support taking jackfruit. As of now, we don't have enough to support saying that jackfruit brings down sugar, or there's not enough evidence. I would not recommend.
I mean, the jackfruit per se would actually increase the sugar, no doubt about it. I mean,
yes.
They talk about the raw jack. Yeah.
He has some component of that, and he says it brings.
Yes.
I'm sorry, I don't have enough belief in that. Yeah. The evidence in that.
Great. So. Thank you so much, Dr. Anjana. That's been it's a great talk, and you have taken the questions so very well for us. I know we can go on for hours on this topic because everybody has their own favorite food and they want to know about it. And I'm sure we all would have had questions about this.
Last question was there on protein powder.
Interesting. Yes.
Yeah.
Okay. So protein powder. So it depends now on what type of protein powder and who is taking it. If you're a vegetarian and you are in the lower BMI category, maybe, yes, we could recommend, but one needs to be careful. We have to look at renal function. We have to look at other things before we advise protein powders. Generally, in the general population, if someone is eating non-vegetarian, and chicken and fish, egg is going in, you don't need an additional protein supplement. In a state like Kerala, there's generally no problem. If you are a vegetarian and you are all under all kinds of restrictions and all that in specified populations, or you are an athlete, and you're looking at certain muscle building or something like that, then an additional protein supplement can be considered. But otherwise, in normal, I'm not at all a person who believes in any supplements of any sort. I believe that health should come from natural foods and things that you eat. The more color you have in your diet, the more antioxidants, minerals, vitamins, protein, everything will come from your food. And I think that's the healthiest way to do it.
Perfect answer, Dr. Anjana. Wonderful. So
yeah.
I think that sums it up very well. Thank you once again, Anjana. Are you going to log off now, or are
I
you
would
going to be
probably
with us
have
first?
to log off now. Yes.
Thank you so much once again.
Thank you. Thank you for
Thank you.
having me. Thank you to the Rotary.
Thank you, Anjana.
Thank
Okay,
you,
right, yeah,
Dr.
Thank you.
Anjana.
yeah.
Okay, so moving on, the next topic is diabetes in children and youth. Is it the same disease as we see in adults? Because we are seeing more and more of children and youth having diabetes. And the question always that comes is it all type 1? Is it type 2? I mean, the type 2 diabetes, which is the diabetes that we have been seeing in older people, we are seeing now more and more in younger people. So is it the same disease? Is it different? To answer this question, we have Dr. Ravindran A.V. He's an internist in Badras Sama Hospital in Oman. He did his MBBS from Calicut and his post-graduation from Hubli. He's from looking through his CV, he's a very prolific writer in many health magazines. So obviously his real interest is in talking to the public, educating the public. So we've got the right person to deal with this topic. Over to you, Dr. Ravindran.
A very good evening to all. Sir, first of all, I would like to thank the organizers, especially Harish sir and Arun sir, for giving me an opportunity to present the topic. Straight away going to the topic, diabetes in children and youth is the same disease in adult. I hope the slides are visible. No?
Yeah.
Yes.
Yes.
So I'll be talking under the following headings. As you all know, diabetes is a group of metabolic disorder characterized by high blood sugar. And the important thing is that the exposure to high blood sugar by various organs can lead to various organ damage, including heart, kidney, brain, and various other organs. So that is the clinical relevance of hyperglycemia or high blood sugar. So high blood sugar produces various symptoms like increased frequency of urination, feeling always hungry and thirsty, feeling tiredness, blurring of vision, and so on. So when we diagnose diabetes, when the fasting blood sugar is more than 126 or 2-hour blood sugar is more than 200, we diagnose diabetes. But once you diagnose diabetes, we have to find out what type of diabetes. There are different types of diabetes. That is type 1 diabetes, which is mainly an immune-mediated disease due to increased destruction of beta cells of pancreas, which produce insulin, or type 2 diabetes, where there is increased insulin resistance, usually seen in obese individual, and other specific type of diabetes and gestational diabetes, that is diabetes seen in pregnancy. So in pediatric age group, the diagnosis of diabetes itself is a challenge. So these are the common types of diabetes seen in pediatric age group. So the one is neonatal diabetes. It's usually seen in children less than 6 months of age. It's of two types, transient or permanent. The most common types are type 1 diabetes and type 2 diabetes. Type 1 diabetes in children and adolescents is usually seen at 6 months or at older age, whereas type 2 is usually seen around the pubertal age group and older groups. And as I already told, in type 1, there is destruction of pancreatic beta cells. So we will be able to demonstrate antibodies, that is autoimmunity, but that will be absent in those who are having type 2 diabetes. And a strong family history of diabetes also point towards the diagnosis of type 2 diabetes. And type 2 diabetes is associated with risk factors like sedentary life habits and obesity. So obesity is also associated with type 2 diabetes. So these are the antibodies that is usually found in people with type 1 diabetes. And when to suspect type 2 diabetes? Overweight or obese individuals, age about 10 years, strong family history of diabetes, presence of acanthosis nigricans. Acanthosis nigricans, as you can see in this diagram, the dark pigmentation over the back of the neck. This is a sign of insulin resistance. So in such cases, we have to suspect type 2 diabetes. And we can probably find out the type of diabetes by finding the age at diagnosis. Usually in children less than 6 months, neonatal diabetes is common. From 6 months to less than 10 years, type 1 diabetes is common. And from 10 years to adolescent up to 25 years, it's both type 1 and type 2. But because of the increased incidence and prevalence of childhood obesity, type 2 diabetes is increased. And all adults at age type 2 diabetes is more common. And you can see this study, the incidence of both type 1 and type 2 diabetes is increasing, but the rate of new cases of type 1 diabetes is increased by about 1.8%, and the rate of new case of type 2 diabetes is increased by 4.8% every year. So coming to the diagnosis of diabetes, as I already told, with increase in the incidence of childhood obesity, type 2 diabetes is increasing in children and adolescent age group. So coming to the pathophysiology, is it same as type 2 diabetes seen in adults? As we know, in adults, obesity and sedentary life habits are the major risk factors, similar factors for the development of type 2 diabetes. Similarly, in pediatric age group and children and adolescent also, obesity and sedentary lifestyles are the predominant risk factors leading to childhood type 2 diabetes. So increasing prevalence of childhood obesity is the major reason for development of type 2 diabetes in younger age group, that is children and adolescents. 80% of the children and adolescents with type 2 diabetes are overweight, and about 40% are clinically obese. And poor dietary habits and lack of exercise and sedentary lifestyles all lead to obesity, and obesity can lead to insulin resistance, high blood cholesterol, high blood pressure, cardiac disease, and diabetes. So increase in sedentary lifestyle has contributed to the type 2 diabetes epidemics, with sharp rise in computer games and TV watching and trend towards abandoning physical education in schools. So fewer children are participating in sports. So obesity in childhood results in not only type 2 diabetes, it can cause high blood pressure, liver disease, respiratory problem, bone and joint problems, sleep apnea, fatigue, recurrent infections, and it can also lead to various psychological issues in children like poor self-esteem, feeling socially isolated, and increased risk of depression. And it can lead to major diseases like stroke, heart disease, etc. So remember, overweight kids become overweight adults. So coming to the natural history, you can see obesity leads to increased insulin resistance, leading to prediabetes and subsequently to overt diabetes. And once person develop diabetes, there is an ongoing exposure to high blood sugar. And this exposes various organs to high blood sugar, leading to atherosclerosis, hypertension, renal, kidney involvement of eye, blindness, kidney failure, heart disease, and diabetic foot issues and amputation. So even those who are developing diabetes, they can develop all these complications. In pediatric age group, it is found that those who are diagnosed to have type 2 diabetes less than 20 years of age, 22% had microalbuminuria, that is involvement of kidney, and that is increased to 60% by 20 to 29 years of age. In a study among school children from Japan, retinopathia, that is eye involvement, was noticed in 36% at the time of diagnosis. And at the mean age of 23 years, 45% of the people developed hypertension requiring treatment, and 38% developed pregnancy loss, reproductive age females, and 9% mortality. Coming to the cardiovascular risk factors in children and adolescents with diabetes, you can see increase in blood pressure, dyslipidemia, metabolic syndrome. All these are increasing in those who are having diabetes. So because of the early onset, they develop complication at an early age, increasing the morbidity and mortality. So the best way to tackle this issue is the preventive measures at each and every level. We have to balance the energy intake with energy expenditure by promoting physical activity and controlling our food habit. So the parents should advise the children to take balanced diet, avoid junk foods, and encourage to do exercise. And schools also should encourage children to increase the physical activity and improve their nutritional status. So the take-home message is type 2 diabetes has changed from a disease of our grandparents and parents to a disease of our children. There is an opportunity to prevent type 2 diabetes in youth by addressing the epidemic of childhood obesity. So by encouraging children to exercise and eat healthy food right from an early age, parents may be able to put a stop to this epidemic and set their children on the road to a long, healthy life. Thank you very much.
Thank you, Dr. Vedan. That was an excellent talk. I think you stuck to time, and I think you're very, it was really clear. So thanks once again. I think we will take the questions in the end, if that's okay. The rest of it, because it's just because Anjana had to leave in between. So the next talk is by Dr. Chandni, who is a professor and head of the Department of Emergency Medicine, Government Medical College, Calicut. And she's going to tell us about the long-term complications of diabetes. I mean, you understand that there's going to be a little bit of duplication of the topics, and there might be a few things that will be said more than once, but that's okay. I think the important thing is that we get the message across. So over to you, Dr. Chandni, for your talk.
Thank you, Dr. Arun. I have already shared my slides. Hope it is okay.
Perfect. Yeah, slides are seen and your voice is audible.
Okay, thank you so much. I'm really thankful for giving me this opportunity to be the part of Rotary seminar on Understand Diabetes, Live a Trouble-Free Life. And I really thank Dr. Harish and Dr. Arun for brilliantly coordinating this program. And Arun is doing a wonderful job as the moderator as well. And my special regards to Professor Katie Molly. She's really representing the nurses who have been helping us all these years in managing diabetes so very perfect. And they are really helping achieving what we really want from our patients. Thank you, sister, for the very clear message, Professor. And I'll be just going through the long-term complications of diabetes. So when we look at the long-term complications of diabetes, we should see who developed these long-term complications. What are the long-term complications of diabetes? Is it possible to prevent? And how to take care of complications? This is what I am trying to say in another 10 minutes. Okay. So you all will remember this red ball with spikes. It's our favorite coronavirus. It has changed the life so differently. And that's why we are all in this platform today. And we know that this COVID is really causing more harm in people who are in the vulnerable group. And the most important in the vulnerable group is diabetes. And diabetes, and that too, the cardiovascular disease is causing more mortality and morbidity in patients with COVID-19. So when we talk of diabetes complications, if I would like to put it in one slide, it involves eyes, heart, kidneys, blood vessels, and feet. And how or what it decides who develop the complication, it is primarily on the duration of diabetes and the glycemic control. If you have longer duration of diabetes, definitely it is going to have a bad effect on our complications. And what we can achieve is to achieve glycemic control from the very beginning of the diabetes. And we know that we have already listened the slides from Dr. Ravindran. If a person develops diabetes at a very young age, as a child, it's really going to do more harm in that child if we move into the adulthood with regard to diabetes complications. And what are the diabetic complications or long-term complications that we are talking about? Primarily, we know that it is the microvascular complications, which include retinopathy, nephropathy, and neuropathy. And the macrovascular complications or the cardiovascular disease, which is primarily the coronary artery disease, which presents to us as chest pain, acute myocardial infarction, cerebrovascular disease, they will be reaching to us with stroke, and peripheral occlusive vascular disease as limb pain or ischemia or blackening of the feet. And there are many other things that has been listed as complications in diabetes like skin manifestations and dental problems. People with diabetes are vulnerable to multiple and complex medical complications, and most important of them is cardiovascular disease. And most patients with diabetes die of a cardiovascular disease. It could be acute myocardial infarction, or it could be heart failure because of the microvascular disease that is happening and the angina and long-term involvement of the heart. And we all know that why do we discuss of long-term complications of diabetes? Or why we are really worried about diabetes? We are worried about diabetes because of the long-term complications like myocardial infarction, stroke, and heart failure. And blindness, that is the most important worrisome complication of diabetes. And kidney failure, transplants, hemodialysis. And the other important thing that we really worried about is lower limb amputation. So how we want to tackle this? It's definitely, we know that we have to know diabetes early. We need to understand and diagnose diabetes early. And when diabetes is not causing any problem to us, we should be addressing it, or we should be tackling glycemic control. This is primarily to prevent the long-term complications of diabetes. Because we usually know that people ask us, I don't have any symptoms related to diabetes that we have been mentioning about. Then why should I control my diabetes? And the answer is very clear. If you really want to delay, or if you really want to prevent diabetes complications, so this is a good message that we can delay or prevent diabetes complications if we diagnose early and if we control diabetes timely and appropriately. So when we talk of diabetes, I think we cannot think of the non-modifiable risk factors as we grow in age, gender above 60 years, but diabetes takes away the protection that women enjoy with regard to cardiovascular disease and family history. And we know that all the previous speakers were highlighting our high risk as with diabetes. So now I have already discussed about the macrovascular complications and how do they present. They come with heart attack, they come with weakness, they come with paralysis of one side, or they come with vessel blockage in the legs like intermittent claudication. There is calf pain, the person exercises. When there is rest pain or pain at night in the calf muscle which is not getting relieved, all these are presentations of the blood vessel blocks that is happening in diabetes. And the other worry is atypical presentations that is happening in diabetes. What are these atypical presentations? They don't have pain, or they have pain in a different form. They come with tiredness, they come with dyspnea, they come with breathlessness, or they come with silent myocardial infarction because they don't perceive pain at all. So there is okay. And how do we assess? We need to assess when the person comes with all these atypical features. We need to assess with electrocardiograms, echo, or if the leg pain, we need to do a Doppler evaluation. So what we want is we need to understand if we behave differently or if we have some new symptoms, we should really consult the physician or treating doctor so that we could have the appropriate disease management and investigations. And we also know this important statement, diabetes as a CH3 equivalent, because it said that diabetes behaves. We have even with first myocardial infarction in a diabetes, it behaves as if you already had an infarction and you're having a repeat infarction, or diabetes disease itself behaves as we have already had a heart attack. And now we move on to the microvascular complications. Microvascular complications primarily affects eye, kidney, and nerve.
Madam, your screen is not seen.
Okay.
Screen is not visualized.
Okay. There was some problem in between. I'll just try to share again. Okay, there was some problem. Some other slide came in between. So I'll just try to share again. Okay. It's okay now, I suppose.
Okay. Thanks.
Okay. Oh, okay. I've been talking about eye disease. Eye involvement of diabetes is the leading cause of blindness in the working age population. That is the worry I already highlighted. And they can come with retinopathy, glaucoma, cataract. And what we need to do is we need to an annual eye examination apart from our control of diabetes and other factors like blood pressure control and all the things that we usually do in diabetic patients. An annual eye examination is a must in all type 2 diabetes mellitus, and in type 1 diabetes, we start doing it from 5th year of diagnosis. And we may need more frequent examinations if the ophthalmologist speaks so. And what we see is normal retina if there is no retinopathy, and the other we grade it as non-proliferative, proliferative, and maculopathy. And this proliferative retinopathy is really causing more damage, and there is new vessel formation, retinal hemorrhages, retinal detachment. So these may present as sudden loss of vision, and these are some of the pictures which shows hemorrhage, exudates, and the new vessels forming, and these new vessels may break and bleed, and all these are causing damage. And what we need to really do is we need to control diabetes from the very beginning, and we need to have a frequent checkup as advised. And with regard to kidney, that is the second microvascular I would like to discuss. It's diabetic nephropathy. How do we recognize? We recognize looking for protein in urine, protein that is not seen by the eyes, that is known as microalbuminuria. And if there is microalbuminuria detected, we can treat with some of the drugs that will prevent loss of protein or damage to the kidneys. And if this is not controlled, it moves to macroalbuminuria, that is more evident protein in urine, and it may lead to impaired kidney function, and patient may go on to maintenance hemodialysis and may end up in renal transplant. So we need to have an annual examination for microalbuminuria, that is protein loss that is not visible by routine examination, and early recognition and treatment. And next one is definitely the nerve disease. Nerve disease, otherwise known as neuropathy. It is diabetic peripheral neuropathy. Longer nerves are more affected, so there is loss of pain. Initially, there may be painful neuropathy, making us difficult to sleep, but as it advances, there is loss of pain. And the other important problem is diabetic autonomic neuropathy, which causes this hypoglycemia unawareness. If you have a nocturnal blood loss, if you have a blood loss at any time, the person will not have the usual symptoms, and patient may go into loss of consciousness. So that is the worry. So in neuropathy with diabetic foot involvement, I know there is definitely a differentiation. So that what we need is an annual foot examination. Oral complications, most important one, periodontitis. This is inflammation of the gums, and this is also known to be increased with cardiovascular disease risk. So we need to have a regular oral checkups. Oral health should be a part of diabetes care. So this is just to show the frothy urine. This means there is macroproteinuria, protein loss. This is an advanced disease. So we need to detect it early. This is a patient with diabetic nephropathy. You can see the person has already got peripheral diabetic neuropathy and ulcers of the feet. And definitely he has got diabetic retinopathy also. Usually they go hand in hand. I'll just put this figure just to say that what is this diabetic neuropathy actually means. This person has neuropathy, and he says he has worn his footwear appropriately, but he doesn't have any idea where his feet is, how he has worn. So there is a total loss of sensation, and he don't know where his feet is actually on the ground or not. This sort of thing is causing more harm to the feet and more injuries and diabetic foot problems, entering into all these risk factors. So we need to understand diabetes, and one size doesn't fit all. My friend or my colleague is having such sort of treatment, they are having such sort of medicine. So whether I should also go or I should also follow up with the same sort of treatment, that is not there in diabetes. We need to individualize, and we need to have a case-to-case based management. And what we need is blood glucose control, blood pressure control, dyslipidemia management, screening for complication, as I already highlighted, the best lifestyle modification that is possible. One thing I would like to add is smoking cessation is very, very important, and including passive smoking. And I think we should have a big campaign, and it's already happening, and it should be stressed again, make everyday world no tobacco day. And routine foot examination is really needed, and this will be discussed already in the coming talk. And one more important point I would like to include, this is not a long-term complication, but psychosocial impacts are huge, and people need real support for managing diabetes. And things don't always happen the way we want them to, and that's okay. And we need to support the patient directly, so that when they move through these complications, they'll be really supported, and they'll be able to tackle it the right way. And in this area, we may need to have a lot of social support when they go into really complications needing more important treatment procedures like dialysis and transplants and other things. And thank you for giving me this opportunity. I've been trying to take you through the important complications. How do we screen, and how do we really want to manage it? And the message is we need to have a good glycemic control from day one. Thank you so much.
Thank you so much, Chandri ma'am. That was crystal clear. I mean, we could I know the passion that you have for patients with diabetes was clear from your voice itself. And that's an excellent presentation. Thank you so much. I think she raised several important points. Now, Harish ji, before we move on, it's 6:50. We are obviously going to overrun time-wise because
Yeah,
there are
anyway,
three.
we'll end up the session. We'll have that this thing. Okay.
Okay, so
Yeah.
we'll see how it
Yeah.
goes.
Yeah.
So
Okay.
the next speaker is Charles Panikel, and he's going to talk about diabetes and liver disease. Now, we talk about so many complications of diabetes. As Chandri ma'am was saying, we always focus on the microvascular disease, on the macrovascular disease. All those wherever blood vessels are there, diabetes is there. Yeah, that's very true. That's what we focus on. But what about liver? Is that a different disease? And is it common? I mean, now we know that the non-alcoholic fatty liver disease and cirrhosis due to diabetes is more common than alcohol-related diabetes itself. And in a state like Kerala, where there is both, diabetes and alcohol, I think only Charles can save us. So over to you, Charles. I mean, Charles is a brilliant gastroenterologist, as we all know. He's currently based in Aster MedCity, Cochin. He's a hepatologist and a liver transplant surgeon, physician. He worked in medical trust before, trained in Trivandrum, both his MD and DM, and he's one of those young hepatologists who is, is actually holding center stage in Cochin. Over to you, Charles.
Arun, can I interrupt one more?
Yes,
Charles is from Pala. Charles is from Pala.
Okay. Oh, that's
yeah, he's a life member of IMA Pala branch. He's a son of a great physician, Dr. Sunny Charles from Pala. Okay. Okay, right.
Thank you, Arun, and thank you, Dr. Harish. And it was a pleasure working under you in Pala.
Welcome, Dr. Charles. Welcome, Dr. Charles.
Thank you. Thank you. When you talk about diabetes and liver disease, you should know that more than 50% of patients with diabetes have liver disease. And liver disease is the fourth leading cause for diabetes in patients, fourth leading cause of death in patients with diabetes. And patients with liver disease can develop diabetes because liver is a main organ that is responsible for the glucose homeostasis and metabolism of insulin. And patients with liver disease can develop diabetes later on in their life. And you can see various forms of liver disease in diabetes, and most common would be just a deranged LFT where you have abnormal SGOT-SGPT when you check your blood, or it may be a fatty liver, and that's otherwise called non-alcoholic fatty liver disease. And rarely patients with diabetes can develop cirrhosis liver. And diabetes is a risk factor for developing primary liver cancer called hepatocellular carcinoma. So you can have that liver disease in the form of just a deranged LFT or a fatty liver or cirrhosis or a liver cancer. And what I will be discussing is mainly non-alcoholic fatty liver disease, or as simply called fatty liver. Sorry. About if you take 100 patients with diabetes, about 75 to 80% will have fatty liver on ultrasound. And of these 100 patients with fatty liver, 70 to 80% will remain stable in the same stage. That's a simple fatty liver or just fat in the liver. But about 20 to 30 patients of 100 will develop damage to your liver cells leading to hepatitis. So you get what is called the steatohepatitis or fatty liver leading to liver cell damage and hepatitis. So if you take 100 patients with diabetes and fatty liver, about 20 to 30 of them will develop damage to liver cell leading to hepatitis. And of these patients with hepatitis, few will develop fibrosis or scarring of the liver. The damaged hepatocytes will be replaced by scar tissue leading to fibrosis of the liver. And when the scarring is more than 50%, it leads to cirrhosis. So about 20 to 30% of your patients with fatty liver will develop hepatitis. And from those patients, about 2 to 7 of them, if you take 100 patients with hepatitis, 2 to 7 of them will progress to cirrhosis. And during any stage, that from the fatty liver, hepatitis, or fibrosis or cirrhosis, at any point of time, if you take 100 patients, about 1 to 2 will develop liver cancer. So you should know that liver cancer, diabetes is a risk factor for liver cancer. And if you take 100 patients with diabetes, about 1 to 2 of them will go on to develop liver cancer. And what determines the progression is mainly your lifestyle, diet, your presence of obesity, your risk factors like diabetes, dyslipidemia. So this determines whether you progress from your stage of fatty liver to hepatitis to fibrosis or cirrhosis. And when you evaluate your patients with diabetes for fatty liver, the first thing that you do is an ultrasound. And ultrasound, you can see fatty liver. It may be graded as grade 1, 2, or 3. That doesn't mean anything. Grade 1, 2, or 3 is just a grading on ultrasound and doesn't mean anything. And when it progresses to a state of hepatitis or liver cell damage, then you see that SGOT, SGPT starts going up. SGOT, SGPT on liver function tests are the enzymes that are inside your liver cells. And when the liver cells are damaged, that get released into your blood, and it goes up in when there's a damage to your liver cells. So when there is steatohepatitis, that is the fatty liver leading to liver cell damage, there's elevation in the SGOT, SGPT in the blood. And when there is fibrosis, that is dictated by the fibroscan. That is, you see the stiffness or hardness of your liver increases. So the basic minimum test that you do in your patients with diabetes and fatty liver is ultrasound. That will show a fatty liver, the liver function test. If there's liver cell damage, you see that the SGOT, SGPT are increased. And if there is fibrosis or hardening or scarring of the liver, then that is picked up by the fibroscan. So these are the basic minimum tests you have to do in your patients with diabetes and liver disease. And you should know that the diabetes is not a disease confined to the liver. It is a multi-system disease, by which what I mean is that the diabetes and the liver disease can affect other systems other than the liver. So diabetes can lead to coronary disease, heart disease. It can lead to kidney disease leading to chronic kidney failure. It can lead to endocrine abnormalities. It can lead to malignancies other than the liver. I said diabetes is a risk factor for hepatocellular carcinoma or primary liver cancer, but the liver disease, the fatty liver can lead to malignancies in other parts of your body, like the lung, the breast, the ovaries, your colon, or the stomach. So it can lead to cancers outside the liver. It can lead to, it's a risk factor for heart disease. So presence of fat in your liver can lead to heart disease. It can lead to kidney disease. It can lead to cancers outside the liver. So that's the importance of treating the fatty liver that you have. And you should know that the most common cause of death in patients with fatty liver is the heart disease. So 38 patients, if you take 100 patients with fatty liver, 38 of them die due to heart disease, not due to liver disease. And 19 of them will die due to non-liver cancer, like breast, lung, ovary, or colon cancer. And only about 10 of them will die due to liver disease. So the fatty liver is a multi-system disease that can affect other parts of the body, and it can lead to heart disease, it can lead to kidney disease, it can lead to endocrine abnormalities, it can lead to malignancies in other parts of the body. And that's the importance of treating your fatty liver. And what's the mainstay of treatment of fatty liver? It's lifestyle interventions. And you should know that if we can achieve 7 to 10% of body weight loss with the lifestyle intervention, that can reverse your fatty liver. So if you are a 90 kg man and you have got fatty liver, if you can reduce the weight to 80 kg, almost 80% chance that your fatty liver will reverse. And that is better than most of the medication that you currently have and medications you will have in future also. So if you can achieve a weight loss of 10% with your lifestyle intervention, your diet, your physical activity, your exercise, then that will reverse your fatty liver. And that is better than any of the medications that you have now or you will have in near future. So that's what I want to highlight today. That lifestyle interventions are the mainstay treatment of fatty liver. But only problem is that even in controlled trials, less than 50% will achieve that 10% weight loss. So even if you strive hard, only less than 50% will achieve that 10% weight loss. So with your lifestyle interventions, with diet, exercise, and physical activity, if we can achieve a 10% weight loss, if we can reduce the weight from 90 to 80, then your fatty liver will reverse, and that's the best form of treatment for your fatty liver. So the mainstay of treatment for fatty liver is weight loss, which you have to aim for a 7 to 10% weight loss with your diet, physical activity, and exercise. And I put physical activity and exercise separate because both are separate, and I'll come to that later. So when you talk about diet, you have to reduce the calorie intake by 500 to 1000 kilocalories per day to achieve a weight loss. So your calorie intake should be less than your calorie burned per day. So your calorie intake should be at least less than 500 to 1000 kilocalories, less than what you burn per day. It doesn't matter whether you take a low carbohydrate or low fat diet, but the calorie intake should be, total calories should be less than 500 to 1000 kilocalories per day. So you have to count your calories. You have to keep a diary and count the calories that you take per day. And you have to make sure that the calories you are deficient by 500 to 1000 kilocalories per day to achieve a weight loss. And you have to have a balanced diet, as Dr. Anjana previously mentioned. You have to have a balanced diet, and you have to take more of fruits and vegetables, and have more of whole grains than refined white flour, or more, take more of whole grains, and take more of healthy proteins, more of plant proteins, and you can take more of fish, plant proteins, and you can take more of nuts and legumes. And you should take less of red meat, processed meat, cheese, bacon, whole cuts. And always restrict your sugar intake. That is, you have to restrict your fructose, your sugar intake to less than 10% of your total calories. And always avoid colas. That's one thing that we always tell our patients. Avoid colas. Avoid Tetra Pak juices that you get in your supermarket. So that contain a lot of fructose, and always avoid them. Avoid alcohol, any form of alcohol. It may be beer, wine, or whiskey or brandy. Avoid alcohol. And one thing that we encourage our patients to take is coffee. So coffee, more than 3 cups per day, has been shown to reduce inflammation, fibrosis, and reduce the risk of liver cancer in patients with fatty liver. So we encourage our patients to take coffee. And when I say coffee, it's the black coffee that I mean, the coffee without sugar and milk, not the coffee with cream and lot of sugar. And coming to the physical activity is any activity that you do from the moment you you get up in the morning to the time you go to sleep. So always try to avoid a sedentary lifestyle. If you are a doctor, if you are a bank manager, or if you are a IT professional, always avoid sitting for a prolonged period in front of your laptop or in your clinic. Always give breaks to your sitting time. So it has been shown that if you sit continuously for more than 3 hours per day, that will lead to increased death from your metabolic diseases. So always every hour give a break. Stand up every hour, walk around for a few seconds, and then sit back. And if you can give breaks to your sedentary time, that will reduce your metabolic disorders. So avoid sedentary lifestyle, and try to take 10,000 steps per day. Always we encourage our patients to use a pedometer, either a watch or even in your mobiles, you have pedometers, and we encourage them to take 10,000 steps per day. From tomorrow on, we'll see how many steps you take per day, and at least for a healthy living, it's recommended that you take at least 10,000 steps per day. And we always encourage our patients to keep reminders so that they get up every hour and walk around for a few minutes before sitting down again. And limit the screen time to 2 hours per day. And exercise is different from physical activity. Just because you exercise for 45 minutes per day and then sit throughout the rest of the time, it won't do any good. So you have to avoid sedentary lifestyle. You have to break your sedentary sitting time. You have to break your sitting time, and at least take 10,000 steps per day, and limit the screen time less than 2 hours per day. And in addition, we encourage our patients to do at least 150 to 200 minutes of exercise per week. It can be divided into 5 to 7 days per week. And exercise may be aerobic exercise or resistance exercise. It doesn't matter what exercise you do, but 150 to 200 minutes per week, that's about 20 minutes per day of either aerobic or resistance exercise, which will help to reduce the fatty liver. So if your patient, if he's obese, he has got osteoarthritis, or he has poor metabolic reserve, and he's not able to do an exercise, you can start by asking him to break his sedentary behavior, asking him to get up every hour and walk a few minutes. Then you can ask him to add few steps per day and increase the steps up to 10,000 steps per day. And gradually, stepwise, you can ask him to increase his activity and add in a resistance exercise, either weight-bearing exercises or stretching. And then you ask him to add at least 10 minutes of exercise per week, That is about 5 to 10 minutes per day, and gradually build it up to 150 minutes per week of aerobic exercise plus 2 to 3 sessions of resistance exercise per week. So the best would be to, if you can achieve a 150 to 300 minutes per week of aerobic exercise and 2 to 3 sessions of resistance exercise per week. So always ask your patient to start slow, because most of your patients with diabetes, they will have comorbidity, they will have coronary disease, they will have osteoarthritis. So always they may not be able to do the aerobic exercise that you want them to do. So always ask them to start slow, ask them to break their sedentary behavior, get up and take 2 steps every few hours, and gradually increase the steps to 10,000 steps per day. And from there, ask them to add in a resistance exercise, like 5 minutes of resistance exercise per day, and then gradually build it up to a 150 to 300 minutes of exercise per week. And that should be your target. And any healthy individual should do at least 150 to 300 minutes of exercise with 2 to 3 sessions of resistance exercise per week. And one important thing that I wanted to mention today is that the journey to your metabolic liver disease starts in the childhood. So your children, it starts in your children. So always limit the screen time. Always limit the time in front of the mobile, in front of the laptop, or in front of the TV. And the journey to the metabolic disease always starts in childhood. And in children, it starts with a metabolic dysfunction, and gradually, once they are in 20s and 30s, develops a metabolic dysfunction, and later in 30 to 40, develops a full-blown metabolic syndrome. So the journey to metabolic disease always starts in children, and always encourage your children to be active, to avoid sedentary lifestyle. Ask them to be physically active and ask them to start exercise, and that will help them in the long term. And in addition to the lifestyle, you have to treat your diabetes. There are a whole lot of drugs that your diabetologist will recommend for you. There are a lot of drugs that can control both the diabetes and the fatty liver, and you have to treat the hypertension, and you have to treat the dyslipidemia. Because as I said, the coronary disease leads to, if we take 100 patients with diabetes and liver disease, about 38 of them die due to coronary disease. And that can be prevented by treating your diabetes, your hypertension, and dyslipidemia. So you have to treat all the comorbidities that you have, and that will help to reduce the mortality in your patients with liver disease and diabetes. And finally, coming to specific liver-directed therapy, that's needed only in patients with steatohepatitis. That is, patients who have got liver cell damage or patients who have got fibrosis. Just because you have a fatty liver on your ultrasound, you don't need a liver-directed therapy. The mainstay therapy is lifestyle interventions, diet and exercise. Liver-directed therapy is needed only if you have got liver cell damage, as evidenced by steatohepatitis on a biopsy or on a non-invasive imaging like an MRI, or if you have got fibrosis. Otherwise, the mainstay treatment is lifestyle interventions. You control your diabetes with drugs recommended by your diabetologist. You control your hypertension. You control your cholesterol and triglycerides. That's the mainstay of treatment for fatty liver in patients with diabetes. Thank you, and happy to take any questions then.
Thank you, Charles. I think we will take the questions in the end, if that's okay, if you can stay for a little while longer. Sure. We've got 2 more talks. One of them would be by myself. So what I'll try and do is Harish ji, you can keep me right time-wise. If are we okay still? Harish is quiet. Yes, he's muted himself.
Yeah, it's fine. Carry on.
Okay.
It's really useful.
Yeah.
Okay, great. So what I'm going to do is just a quick snapshot of the problem, that one of the commonest problems that we are facing, which is, let me just go through Charles' slides. I think I have all these slides. Sorry. Okay, so diabetic foot and preventing amputations. Now, there are so many people who still ask me, do we still amputate? Is foot problem so common? Why are foot problems common despite having so many good treatments for diabetes and all these treatments? You know, this day and age, we should not be amputating anybody. Unfortunately, the amputation is the result of very long-standing diabetes and many a times a lack of care about their foot problem. So I can't overemphasize that point more than anything else, because unfortunately, many of the amputations that we see in our practice, I would say that it is very common. All hospitals have so many people who are having either minor amputations. When I say minor, we are talking about the digits, just the big toe or one of the toes or whatever, to major amputations, which is midfoot, below knee, above knee. Now, this is still happening quite a bit. Why is that? I think that's what I would like to. So I wouldn't scare you with this picture. I'll just take it off. But I think what you need to understand is that the 85% of diabetic foot amputations are preceded by a foot ulcer. So when you see a foot ulcer, if we are as careful as we can be, many a times, I'm not saying always, many a times you can avoid a foot amputation. The problem comes when you delay it because you think, oh, it's just a callus, it is just a caliper or whatever, and we say, oh, it's okay, I'll just dress it. Now, what we forget is that underneath that, there are problems. I'll come to that later. And also, you need to understand that 10% is the prevalence of foot ulcers in diabetes. So it's not uncommon. So you have 10 people with diabetes, one person will have ulcer. That's a prevalence. So that is a big problem in itself. Why is it a big problem? It's a big problem because what you're seeing in a ulcer, in a diabetic foot ulcer, is like tip of an iceberg. And I think if nothing else you remember from my presentation, this is what I would like you to remember. That is, this is the bit we are seeing. This big bit we are not seeing. So what is this big bit we are talking about? So you see a small ulcer and you think, it's a small ulcer, it will heal. Like one patient who told me yesterday, everything heals for me, I have no problem. His HbA1c is 10. He has never looked after his diabetes, but he says, my wounds always heal, so I'm not bothered. But what is underneath is what we should think about. What is underneath? It's a long duration of diabetes, of poor control, which leads to occlusion of blood vessels. So your vascularity or your blood supply is very poor. So when your blood supply is poor, whatever medicines you give is not going to heal that ulcer. Add to that is the poor quality of skin, the poor quality of the nerves, what we call as neuropathy. So you have neuropathy, you have reduced vascularity, you have poor skin condition, and then you get all sorts of bad infections in diabetes, because many of these, it's polymicrobial, let's call it, because there are a number of bacteria that would get into a diabetic wound. So it is difficult to heal. So what you see on the top is not what you get underneath. So this is how it starts. It starts as a very small ulcer. People don't take care. They walk on it. Remember, you're putting a weight of 60 or 70 kg or 80 or whatever your weight is on that small ulcer all the time when you're walking. So if you don't offload, and if you're walking without a proper footwear, again, this is the other point. I think Anjana touched upon that, I think, or Chandri ma'am did. So what happens is this small thing, unfortunately, can't heal. It will not heal because you're putting weight on it. And what happens? It comes to something like this. And then what happens? And then you get deformities. Why do you get deformities? Because you don't feel the pain, the bones crumple, you get what we call as Charcots. I'm not going to go into all the details of this, but these deformities will cause new ulcers because the foot has lost its shape. So the wrong part of the foot is carrying your weight, and that leads to ulcers. And this is the end result, unfortunately. And this is what we are seeing quite a lot. So as I said earlier, the reasons for this are the long duration of diabetes, the very, very long duration of diabetes, the poor glucose control that delays the healing, the nerve damage, and poor circulation. Now, again, patients tell me, no, I'm fine, my foot is okay. You can't know that unless you test it, largely because many of these are asymptomatic. So when you have nerve damage, you don't, many a times you may not have pain. You actually don't, you have loss of sensation, loss of pain. And many times you wouldn't know that. So, I mean, as Chandri was showing that picture, he thinks that he's wearing a footwear, but that footwear is nowhere on his foot, isn't it? It's all over the place. So it's on the floor, really. So that is one problem. The circulation, circulation is not something which you can just see by, if you're just looking at the foot, you can't see, unless it's, of course, very severe, then it's very bad circulation. So you have to get this tested. you have to look after your feet by simple measures. And I'm not going to go into treatments or anything of this, but this is just the last slide, but I want you to look at this slide in a bit more detail. What does this slide say? The important thing with foot care in diabetes is that you do not walk barefoot. I think that is the most important message you can give to your patients with diabetes. There are still so many people who have 20, 30 years of diabetes who walk barefoot. That is not acceptable because that is a start of a problem. So it is lack of care that leads to this. The second is you have to inspect your feet daily for blisters, wounds, bleeding, warmth. Why daily? Because if you have a blister, you will not know. Your sensation will certainly be less than usual. So you have to, if you look, you will see. Then do not apply hot fomentation. I think this is the biggest mistake. We see time and again, we still see it, despite years and years of education to everybody, to the common, to the public, to the layman, people still apply all sorts of things and hot oils and hot this thing and cold oils and all sorts of things. And you feel, you always feel better when you put anything warm, isn't it? That's how it is, you feel warm. But unfortunately, the skin is of poor quality. And if the skin breaks, that is the start of a big, big problem. So I think please don't apply anything on your foot unless you get a proper advice from a physician who actually knows about this. Use correct footwear. Again, can't overemphasize that point. So just wearing something and saying, this is comfortable for me, unfortunately doesn't, because even if one of the pressure areas gets a wrong pressure on from that footwear, that will lead to problems. Okay. And as we said, do not walk bearing weight on the affected foot. So once you have an ulcer, you really have to offload. That is important. Do not sit cross-legged for a long time. Why? Because the circulation could be affected. Do not remove footwear during travel. Again, that goes without saying. Cut the nails regularly, trim square, but those get it cut by somebody who actually can look at it either by a professional or by if your partner can do it. But you have to make sure that it's done properly and there is no bleeding that happens there, because a bleeding could be a nidus for start of an infection. So you have to cut your nails, you have to keep it clean, but do it properly, get the right advice, and the advice is out there anyway. And then clean your feet twice daily with soap and water. Wipe the web spaces, the web spaces, the ones between the digits. That is the area of problems, start of problems. Why? Because there is always the chance the skin becomes dry, the skin gets crusted, it breaks, and the infection gets in from there. So these are the advices that we should give to our family members, our friends, whoever has long-standing diabetes. These are the things that they should take care. I think there are lots of treatments available, but we don't want to go in there. Why do you want to go into treatment? Because the treatment, unfortunately, doesn't give you the right results, because many a times it's long drawn out treatment. It's a chronic disease. It leads to problems, sometimes even amputation. So I would conclude by saying diabetic foot is very, very common. The results of years of poor control and damage to circulation is what causes it, along with neuropathy. It's a chronic disease. So let's not look for magical solution for an ulcer and suddenly healing. If you have, there are studies that have very clearly shown that if you have one ulcer, then your chance of further ulcerations in that same foot, or actually in the opposite foot, increases significantly. So it is a recurrent problem. It's not going to just end with one ulcer. Amputation is still a common end result, so we have to prevent it. And the best thing is to prevent it, because cure is more difficult. So I'll stop there, and I will get in my good friend, Dr. Suresh, who is hiding in somewhere there, who I think is there somewhere, isn't it? He has been very quiet. And he's going to tell us, that's going to be the last talk, and he's going to talk to us about the facts and myths of diabetes treatment. And I think this is an important area, because many a times we see people going about all sorts of, I would call it as a mixopathy. People are on all sorts of things. So they're on insulin, they're on some tablets that their neighbor was taking, their friend was taking, somebody else was taking, plus then some this thing that somebody had suggested, some kashayam from here, some this thing, some manual. So it's a combination of treatments that people are trying. unfortunately, many of these combinations are not time and tested. So you are using yourself as a guinea pig when it comes to that. I'm sure Suresh will elaborate on this facts much more. So over to you, Suresh. I mean, just to a quick introduction of Suresh. He's one of the high-flying endocrinologists in Coimbatore, where he's in Ramakrishna Hospital, Sri Ramakrishna Hospital in Coimbatore. He's the lead consultant there. He did his training from Coimbatore and then from UK, and has been back here for more than a decade. And he works between UK and here at times, but he makes his presence felt in both countries. So he's a very vibrant endocrinologist. Over to you, Suresh, for your talk.
Can you hear me, Arun?
Yes,
Can you hear me?
yeah. Yes, we can, and we can see your slides as well. Yeah.
Yeah, thank you very much for the wonderful introduction. I think, sorry, Sunday, being a Sunday, you and me, probably all of the endocrinologists, we're having so many meetings in between. And thank you for patiently waiting. Almost 70 to 80 people are patiently waiting. And it's been an honor to be there. I have to thank Dr. Harish for involving me, and good friend, Dr. Arun, we've been in touch for so many years from England. Now, I think my job is so simplified because of all the talks that has been gone through. And if I can drive the message in next 4 or 5 minutes or so, and then we can have a talk just with the questions. And we got a huge challenge of diabetes, and we are becoming from, what do you say, the diabetes capital of the world. We want to become diabetes care capital of the world. That is the whole point of having a lot of discussions and everything. Previously, about 7-8 years ago or 10 years ago, people don't do a blood checkup and everything very commonly. Nowadays, even the master health checkups and other things, they include blood sugar in a big way, and that is a huge change. And as Arun was mentioning earlier in his introduction, he was saying that a lot of people will be getting into epidemic of diabetic. So there are a lot of challenges and people's misnomer and what they think, okay, one of the relatives in their family have got diabetes, and they might have gone into a renal failure just before they put on insulin. So 1 month after they put on insulin, they'll go into a kidney failure. They'll think, okay, that is because of insulin. And they will come up with the idea saying, doctor, we are just don't want insulin because insulin causes kidney failure. So many things, especially in Kerala area, there are a lot of alternative medicine with Ayurveda and other old ancient treatments are on. I know that our allopathic doctors have had a huge challenge of managing the whole treatment, leave alone diabetes, whole lot of rheumatology and other chronic disease, and even the heart disease. People say they'll have a kashayam and get a heart disease away. I mean, there are a lot of misnomers. So I'll just go through a few slides about just generally about diabetes, and then very quickly about the management one. And people think that diabetes is not a big deal, but diabetes, if you take it, it's a blood vessel disease. So the small blood vessels will supply the blood to the eyes, kidneys, and legs, and the big blood vessel supplies to the heart and brain. So blood vessel closure, if I want to make it simplify for you, it is a vascular disease. Blood vessel closure is diabetes. So if the blood sugar goes up, the blood vessel closes very fast. So that leads to blindness, for example, when the eyes goes off and the kidney dialysis or this thing, and the heart will have a heart attack and the brain will have a stroke. This is not to frighten you or anything, but that's the way the progression of the diabetes. So it is a big deal, and the people must know about the special diet. I think if you start with the healthy diet, what you normally do, there are so many questions to Anjana about the diet. But I think if you look at the diet, what we normally for a healthy living, that should be continued for diabetes as well. And people asked about so much about honey, that thing, this thing, and it's mainly the diabetes friendly and sugar free good is very good for you. And people take I know people taking 4 packets of sugar free just because they're taking sugar free, and they were having other alternative things to sugar. But I think fructose and other everything is a carbohydrate, so we should have it very judiciously. Sugar free food obtains plenty of calories and fats, even carbohydrates, so you should check the nutrition label very, very carefully. In India, the marketing is so easy. People do sugar free, diabetes friendly, and all this thing, the diabetes free chai, diabetes free coffee, so many things are marketed in India. Nobody has got a restriction. And the best of the things I heard in Kerala is people from Coimbatore, they just get a lorry and go to Kerala because one of the doctors give laddu for diabetes treatment. So I don't know what he does, but I think he gives laddu and the people get sweet and then get a treatment for diabetes. They think it goes away, but in fact, he gives some sulfonylurea tablet inside hiding in there. So there's so many myths are going around. Exercise always leading to, why should I do? I'm already lean, doctor. Why should I do an exercise? Exercise will lose more weight. No, it is not for losing weight. It will make the insulin to work better. So if you look at the muscle fiber, if the muscle fiber works, the insulin will be acting better. So when the insulin acts, as you know, in the simple brain, you may be a scientist or a businessman, but if the insulin works, the blood sugar comes down automatically. So exercise is not for weight loss alone. Muscle strengthening exercises or all other yoga and other quite alternative exercises you could do. And people say that, okay, I cannot donate blood, but no, you can donate blood. It's not a problem as long as your diabetes is not poorly controlled, extremely poor control. I don't know how many people will know the normal blood sugar HbA1c control, which is the 3 months average. I'm sure there was a first or second lecture on that. So if it is more than, for example, 8 or 9 or 10, something like that, it is a poor control, then you cannot donate blood. Women with diabetes should not get pregnant. That is a real misnomer. If the control is bad, yes, they should not get pregnant. Why? Because if they have a high blood sugar, it means that the child will be very defective. They'll have a cleft lip, they'll have a heart problem, and you have to take the child whole life to hospital and stuff. It is not to frighten you, but if you got a lady who's got a poor diabetes control, then not to get pregnant. That is the only point you need to know. And about the gestational diabetes, people don't know what gestational diabetes is. It is the diabetes that coming during pregnancy, and they'll ask, okay, doctor, this comes only in pregnancy and goes away after that, so I don't need to bother. I'll just take very judicious precautions during pregnancy, but after that I don't need to bother. No, I think what happens is, I've seen all the pregnant ladies are very, very careful. They'll come with their moms and the husbands. They will be, whatever you tell, you ask them to buy a glucometer, they buy it. You ask them to maintain a diary, they buy it. You ask them to do walking, they will do it. Everything they will do it for that 8-9 months, very, very sincerely. But after that, they won't do anything. So that is the biggest mistake, because that is where Arun has shown a diagram of that tip of the iceberg. We are seeing so many people who are missed out just because of not being diagnosed. So gestational diabetes is the one that needs to be taken care. And insulin usage during pregnancy, I'm pricking, doctor, I'm pricking in the stomach and it will harm the baby, or I'm pricking myself and it will harm the baby. No, not at all. In fact, insulin is the main gold standard treatment for pregnancy people with diabetes. And the individual with diabetes can eat wheat but not rice, and they say, oh doctor, I'm eating only chapati, there's no problem, I don't eat rice at all. No, chapati is also a carbohydrate, or a wheat is also a carbohydrate. We should be very, very careful about that. And then people with diabetes cannot eat sweets and chocolate. This gives you in India a lot of people marketing like diabetes free sweets, diabetes free chocolate. There's so many marketing gimmicks are going on. You should be extremely careful. It is like anything, it is just like a moderation you can have now and then, and it's a very special occasion, very small portion can be done. And I know when my blood sugar is, and there are so many people, they might be so successful in business in a solar or in Coimbatore area, so many businessmen are there. They'll implement their business knowledge in diabetes and thinking, doctor, I know my blood sugar is going up and I know when it's going up and when it goes down. So I don't need to when I feel low, then I will take some chocolates or this thing. So what happens is that is called defense snacking. So they eat more and more and the sugar will get worse and worse, because it may not be the case that they will have a low blood sugar at all. So they just eat and eat just to avoid something that is coming through your brain. So you won't be knowing whether your blood sugar goes up, or you might be in rare occasions, but not always. So you should always be confident when you check your blood sugar and make sure that is the case. And this is the very important fact about the medicines in Coimbatore area. At least there is so many people says, doctor, they're taking all the medicines, destroy my kidney. And so I don't want to continue with these tablets. And they go for alternative medicines. And you know what happens? The 20 to 25% of the dialysis and the renal transplant happens for people who are taking some sort of rubbish tablets or something that is not labeled or that doesn't know what the content is. There is a heavy metal in the tablets. So it is not to frighten you. It is not that we are doing allopathic practice and saying alternative medicine or something is bad. It is to say there are so many instances that we see in front of our eyes, people going the kidney wise and they crying at that stage, doctor, I shouldn't have done taking some medicine that has been given, saying that you are got no side effect sort of thing. People go saying that, okay, these English medicines are all got side effect, and go for an alternative without knowing what it is, and then just they come up with all sort of complicated problems, especially the kidneys, because all the heavy metals have to filter through kidneys and it damages it in a big time. So a very important aspect of my talk is just the myths that is coming around the treatment. So I'm on insulin because I've failed to control my diabetes. The people say, okay, doctor, I'm in the end stage of diabetes. That is why that my sugar, you're asking me to do insulin. I don't want insulin because of that. No, insulin is not your fault. It is just the pancreas. It is one of the mechanisms that pancreas is stop secreting or reducing the beta cells, which is the main producing agent, is producing very less insulin, and that is why we want you to have an insulin. It's not because of your fault, or it's not an end stage of the disease. And sometimes we give insulin for anabolic activity. You know, anabolic activity, there's two things in metabolism. One is the anabolism, another one is the catabolism. Anabolism is building up, and catabolism is breaking down. So anabolic effect, we give insulin, and people say insulin is a shot, just all the pain, but there is no benefit from it. No, it is not like that. There are so much modern insulin is coming, 4 millimeter needle, even if you just like a feather touch, the needles are there. And it is very, very, very easy for people to take it. The kids take them for school, and so much modern insulin with the needles of 4 mm, it's just feather touch. And it does so much benefit, and it does good for the heart and blood sugar lowering, thereby reducing the whole lot of complications. So insulin are going to be a drill in a big hole in my pocket, doctor. I'm going to take insulin, and it's going to be huge expense. No, diabetes itself is a huge expense, at least. But I think now most of the government or the state governments are giving it free. And also, if you look at the insulin itself, if it is cost more than 150, 200 rupees, it's much cheaper than a lot of oral medicines. Even oral medicines can go up to 70 to 80 rupees one tablet. So that means you take it for 30 days, you're talking about 2,400 rupees compared to 140 rupees of insulin. So it is cheaper, and governments are giving it. So it is not true as well. And maybe I'm addicted to insulin. This is the thing. A lot of population with a lot of different there are so much beliefs in groups, religions, and sectors of industrialists, whatever. So they say that I'm addicted to insulin. No, it is a myth, complete myth. The insulin is a natural substance. That is, it is a God-given hormone in our body. It is a hormone, and that is lacking. That's why we are giving it from outside, and sometimes we give it for some other reason. So the almost the fifth one is I'm on insulin, means I'm in the last stage of disease. I think I've dealt with that. You have to fear of this thing, and people say I'm in end stage. And my cousin had insulin when she had a renal failure, and she died within 1 month. No, it is not true. It is not at all true. In fact, with the modern insulins, so insulin is given for very, very, very good reasons. So if I take insulin, I put on excess weight. This can be true because insulin is an anabolic hormone. It can be true, but it's not completely true, that in the sense that if you take insulin, that body gains weight because it is going into the right track, and your body goes into a right sort of mechanism or metabolism, so that you can carry on with your life. So you can do with a dietitian and make sure the diet and exercise will be the key of this thing. And if I take insulin, so you can eat anything. Just you counseled me, you convinced me to take insulin, doctor. Now I'm going to eat for everything. No, I think you cannot do that, because if you just add on extra calories, you will gain more weight. And if you gain more weight, the insulin, if you're giving 10 units, you will have to give 14 units. So it has to go up and up. So it can't be possible. If I'm sick, whether I should stop insulin, no, it is not the case. as I've explained to you, insulin is an anabolic hormone. It is needed for body's metabolism. So during my illness, I think insulin is one of the key things that needs to be added on. So, and then people comes to the diet. I think I will be very quick because Anjana has covered most of the things. So people say starch is completely bad, but it is not true. Fiber is one of the important components, and then high fiber diets is very, very, very important for the diet. And people with the diabetes should eat loads and loads of protein. There are so many diets which came in. I think one of the diets which came in with paleo and Atkins diet and everything is so much fat and so much protein in. People will die of other heart disease and other things. So yes, protein is needed for a lot of other things like body repair and everything. And even corona time, that lot of protein is needed for immunity. There is no question about it, but it's not only protein that is needed. And people don't have to worry about eating fat because it doesn't affect the blood sugar. Yes, it may not affect the blood sugar like a diet like a paleo and other things. You just load with a lot of fat, but it does affect the heart disease. Even a diet called Atkins diet, when we were in England, it's so much famous. Even the person who found out Atkin himself is died of heart disease. So it is very important that you should be avoiding too much of fat, and Anjana has explained saturated and unsaturated fat. So people say, okay, I'm not going to eat snack at all. You can have a snack, like especially people are on insulin, they can have a snack, but the key thing is to plan for a low fat, low calorie snack. If you plan that very well, snack is not an issue at all. So my point is, I think the quality is very important than the quantity. Doctor, they say, oh, I eat only small amount of rice. No, I think it is the quality which is very important than the quantity. Almost end of my talk. I think the key point is that people talk about food, and as Arun was mentioning earlier, people will have their own food and they talk about it, but food is the most abused anxiety drug. Exercise is the most underutilized antidepressant. This is one of the favorite slides actually. So these are the things, food and exercise are the main thing that needs to be concentrated. If you don't concentrate in food, 1/4 of what you eat it is for keep you alive, and other thing keeps us alive, you know. So it is an Egyptian proverb, so you have to pay it for the hospital, you know. So and then when you come to exercise, we have to get exercise in a big way. I think if you don't, and we are all stuck to our couches in a big way, so we really need to move on and get the exercise done. Not like this lady, the doctor asked them to go for a treadmill, and you can see what she's doing. She's in a treadmill in a chair. So, and this is a joke that problem is that obesity runs in a family. No problem is that no one runs in your family. So sadly, I think what you do is you tell patients, and then they come up with a lot of escape moves, or lot of reasons in the clinic to say that, okay, the mistake is not theirs and its mistake is yours, sort of thing. But I talk to them and say that it is purely that I think diet and exercise is a lifestyle disease, and we have to take it. And how you take the disease, like for example, if you attack our single soldier, we declare war. Like USA's attitude, if you declare attack us, we'll wipe the country out of your map. If your country will stop playing cricket with you. So it is like an attitude that that we need to change. And a lot of myths are going around, but needs a clear explanation. And as we said, I think the nurse are the key people in the management of diabetes. I respect them in a big way, and I'm planning to do a big program for nurses for diabetes related thing, because this November Diabetes Awareness Month is dedicated to the nurses. So I stop there, and any questions I'm happy to answer.
Thank you very much, Suresh. Thank you. That's a great talk. So I think what I'll do is I'll probably just summarize in 5 or 6 points what we have discussed over the last hour and a half before we take questions. There are quite a lot of questions. I think Suresh, Chandni, Mohan are all going to be very busy after this. I'll keep quiet. I'll just ask them to take the questions. But so I think what the speakers have told you today, if I could sum up, is that diabetes is not just a metabolic disease. It is also a vascular disease. So your blood vessels get affected. You talk about the metabolic problems in sugar, cholesterol and all, but it's also a vascular disease, okay? And the other point being the early onset diabetes. The biggest problems with early onset diabetes is that it is more aggressive, and these people have to live longer with these complications, because we have treatments to, people survive with these complications nowadays because there are treatments. But unfortunately, these treatments are not 100% effective. So what do you live with disabilities throughout your life. So if you get it young, you're going to have longer life with disabilities. I think that is unfortunately the biggest problem. So we have to prevent as much as possible. We have to delay the diabetes as much as possible. I think that's another point that came out. Cure is still a dream. I think people need to understand that cure is still a dream. Please don't go after cure. I think that is the biggest mistake that we see people doing. Of course, remission is possible. Remission is certainly possible. You can remit your disease. You can keep it under check. You can, good lifestyle, do that way. But there's no point in going on good exercise and diet for a few months, getting your sugars controlled, showing to your doctor that your HbA1c is 5.7, and then going back to your previous ways. It will come back. Whatever you do, it will come back. So it is for life. You have to change your lifestyle for life. I think that's another important point. And I think Rotary has got a big role to play in getting all these messages across. I think doctors, I wouldn't be pessimistic, but I think as doctors, we have not succeeded. I wouldn't say we have failed, but we have not succeeded in sending all the right messages to everybody. So organization like Rotary, which has huge impact all over the world. I know Rotary also already has done so much of work in retinopathy, for example. There's so many areas where Rotary has already done quite a bit of work, but we need to continue to educate people more than anything else, more than spending funds on treatments and all that. It is mainly on educating people. I think that's basic. So please understand that it is a silent disease. Please don't tell that I don't have any symptoms, though I'm fine. It's not. You will not have any symptoms. Don't wait to get any symptoms, because if you have got symptoms, then you're already late. I think that's a message. Okay, so with that, I will take questions, and I think there are quite a few questions. So can I take that one by one and ask my co-speakers to answer that? So there's one question. Is there microalbuminuria increase in obese people? Who would want to take it? Chandri ma'am?
Yes.
Yeah.
Microalbuminuria. Obesity itself is known to be a risk factor for albuminuria. And we know that obesity otherwise also is a risk factor for all the like diabetes, obstructive sleep apnea, and all those things. And they are all accepted risk factors, and we need to control obesity.
Okay, so that is one question. Sorry, but the chat box has disappeared. Where is the chat box? Okay, now the next question from Dr. Thomas Carpen is: any relation between diabetes onset and vitamin D deficiency? Suresh, do you want to take that question?
Sorry, what is the question?
Diabetes onset and vitamin D deficiency. Any relation?
There is a lot of there is no direct relationship. The vitamin D receptors are found in multiple places. There is some evidence with vitamin D deficiency showing direct relationship with diabetes initiation. But as you know, this is a multifactorial disease. This is not a disease that comes in with one thing. Okay, vitamin D and you are getting diabetes. It doesn't happen like that. So what they found out is that vitamin D deficiency, the people with diabetes have got vitamin D deficiency, and they found out the mechanism that the vitamin D receptors are there in existing in most in beta cells and other things where the insulin is produced. So a lot of science going in that area. Yes, there is an association, but not an association saying that if you do vitamin D replacement, diabetes won't go away. So don't go into that, or don't buy anything in that.
And another question, you can take that also. Any relation between paronychia and pre-diabetes?
Paronychia and pre-diabetes. Paronychia is nothing but fungal infection.
Yeah.
Fungal infection can come with even just a obesity as such. If you got a grossly obese, you can have a superficial fungus, candida and paronychia. It can come. But pre-diabetes, there are evidence to have a paronychia, no question about it. But mostly it will happen with diabetics.
Okay. Now, is Charles there? Charles, has he gone?
I'm here.
Oh, hi, Charles. So the question for you. You're an expert on alcohol, I presume. Please comment on alcohol and diabetes. That's a question from
No,
Dr.
I can comment on alcohol and liver disease.
Right, okay.
Yeah.
And diabetes.
Yeah.
So that is a question.
Yeah.
But I think your talk was on that, isn't it? On both aspects of liver disease. Yeah.
There are lots of literature on alcohol and liver disease in diabetes. And I don't think you should, if you are a diabetic and if you have got a fat liver, I don't think you should be taking alcohol. Because many literature comes from France where they have looked at red wine being beneficial for fatty liver, and the red wine contains a lot of antioxidants. And so
I think the long and short of it is, I think abstinence is what you would advise, but probably in a very small quantity, it's probably not going to. It's not going to make a problem.
If you take alcohol, if you are a diabetic, you have got fat liver. If you take alcohol, it will add on to your liver disease. So you should not be taking alcohol when you are a diabetic.
Thank you, Charles. Then a question specifically to me, Dr. Arun, in your talk, 10 commandments, you mentioned that don't remove your footwear during journey. Why? I mean, I suppose what it means is that in a journey, you might be putting it on surfaces that you are not sure about. At least at home, you know what you are stepping on, or hopefully you know what kind of floor you have at home. You still shouldn't be doing it at home. So even more so in journey. I mean, you know, just a car journey or a train journey or whatever, you don't know what is on the floor, and you might, there might be pressure for quite a long time on one point of the foot, and that could actually lead on to damage there, some hematoma that can actually break off. So it is because it is, a journey, you are not sure what sort of surface you're keeping your feet on, and that could be a problem. So that is what it is. Now, another question is relation between gluten and diabetes. Does Charles want to take that?
And and one more question is there: insulin and insulin resistance and insulin. Same person.
No, that comes later, I think, isn't it?
Okay.
Yeah. I'm just going in the order. So relation between gluten and diabetes. Charles, if you're there, do you want to take it?
No, you're asking me or?
Yes, Charles. Gluten and diabetes.
Pardon?
Gluten.
I'm not sure.
Okay, fine. So I think
both are autoimmune diseases, and you can have type 1 diabetes.
Yeah, absolutely. So in type 1, in type 1 you have
if you have a type 1 diabetes, then you have got a celiac disease, and there's association. Otherwise, no.
Yeah. Fine. Thank you.
Anything else you want to add, Arun? I'm not sure.
Yeah. I don't know. Is Mohan there? Mohan probably. I think Anjana is left. The other question is, could consuming seasonal fruits like jackfruits, mangoes in large quantities by non-diabetic persons trigger diabetes? Can Chandini ma'am take this question?
I don't think it's not that you take more sweet you will get diabetes, but it's better to control sugars, because obesity will definitely add on to your weight and future risk of developing diabetes.
Exactly. I think it's an indirect effect rather than a direct effect. So just jackfruit and mango is not going to cause diabetes per se, but if you're eating too much, I think that's what, in large quantities. Yes, of course, because eating too much of any carbohydrate is going to, whether it triggers diabetes is difficult, but if you're obesity, and indirectly that would cause diabetes. So that is the answer to that. Then another question is, my question is that I'm a diabetic for more than 25 years and age 65, presently managing with tablets, otherwise active. To be more safe, should I switch to insulin? Suresh, you're the right person to answer this question. If you're there, Suresh.
Just in the Endocrine Society India's GBM as well. No, it's okay. Just if you don't mind repeating the question, Arun, sorry.
The question is, diabetic, 25 years, age more than 65, presently on tablets, otherwise active. To be more safe, should I switch on to insulin?
No, not at all. I think if you somebody has asked the same question, that insulin resistance is there, why do you want to give insulin? So it is applies, the same thing applies actually. If it is a 60-year-old, sorry about that.
So I think there is some disturbance, Suresh. Is that Can you just mute that one for a minute?
Yeah, I need to.
I can't hear you.
Yeah.
Thank you.
This Endocrine Society meeting.
Yeah, I know. Thank you.
Sorry. The answer is no, that you should not stop the tablet and go on insulin. just simply because your mechanism, there is almost 8 mechanism to get into diabetes. A lot of hormones, GLP-1 and neurotransmitters and insulin secretory defect, insulin resistance and other things. So insulin resistant people who already body secreted the insulin, and insulin there in the body already, but it's not working. That's why you have to give insulin to the tablet to them to make sure that the insulin is working better, and the exercise will also make sure that the insulin is working better. In those people, you give insulin for what? You're adding on insulin and insulin, they won't have a good control. So you are 60-year-old, your control is much better. You need to continue with the tablets what you're on, and probably go to an endocrinologist to make sure you're on the right group of tablets, so that all the pathology is addressed. Diabetes is about addressing all the pathologies so that you are on the right sort of tablets to make sure that you get a better result in terms of preventing complications.
Okay. So I think if I can add on, Dr. Kapan, your question.
What tablets for insulin resistance he's asking?
Oh, all, I mean, so I think we'll not go into specifics of it. Probably it's probably a more personal discussion, but things like metformin is an insulin sensitizer. It is the commonest one, and there are quite a few others, glitazones and all that. We'll not go into specific discussion, but I think the important thing, it's a message that insulin resistance is only part of the problem. So this question of, oh, I have insulin resistance, so why should I take insulin is not right, because at some point you become insulin deficient as well. Your beta cells continue to decline. Its function continues to decline. At some point, your insulin resistance is not the only problem. You have two problems. And so initial attempt is to control the insulin resistance with tablets. Your tablets are not 100% effective. We know that, and it might not be effective after 5 years or 10 years. That is when, because most of the complications of diabetes is due to the glucose itself, isn't it? High glucose. So when you don't have a way to control your sugars, then the best one or the last resort is insulin. So that is why insulin would be given, because it's very effective treatment. So if you can control the glucose, then you can actually prevent the complications. I think that's what. So if, for argument's sake, if you have got better tablets in the next 5 years or 10 years, which will control insulin resistance, by all means, yes, we should go on that. So we are talking about the current treatment. So people with insulin resistance, first we'll have tablets, which are insulin sensitizers. This is very non-specific, very general discussion. And then if they're not getting controlled on it, you should have a discussion with your doctor as to whether insulin is the right thing. Now, people are different. People will have different treatments. Different things would suit different people. So it's customization more than a general statement there. Now, the next question is, will taking statin lead to diabetes? Chandri ma'am, do you want to take that question?
There are some studies, there is a minimal risk, but we have already shown it many times that taking statin in the right dose for the right persons, it's always having more benefits than the mild increased risk that has already been discussed. So I think if we are asked to take statin for any specific indication, that is protective and that has more advantage than the minimal risk of developing diabetes. So statin should be continued.
Okay, so that is clear, isn't it? The benefit far outweighs the risk. But once you have diabetes, then what's the reluctance to take statin? Your diabetes is not going to get worsened by statins. There is no real evidence to say that your diabetes controlled by itself will not get worse by statin. You will get protection of the statin once you have diabetes. So once you have statin, this argument of saying it will cause diabetes doesn't hold true, because you already have diabetes. So you better get the protection of statins. So that is why statins are prescribed for people with high cardiovascular risk. Okay. Now the next question: all speakers are stressing on diet and exercise, which should be the primary management. But can you highlight on the important benefits of social activity or happiness chemicals, which is relevant to us? Oh, wonderful question. I think you guys know that better than me, so I am not going to go there. So the question is, yes, exercise, diet and exercise. What about stress, and what about stress relief? I think you guys know that better. I'm sure you have all done it. So yes, stress relieving is what is required. You should do all good social activities. You should do, stress relieving, starting from, we talk about meditation, yoga. All these things are not proven, but we know that reducing the stress will help, but it's difficult to quantify it. So I think that certainly is a nice question. Now, please be in speaker view to view all the panelists all together. No, I don't know what that is. Please in speaker view to view all the panelists together. Okay. Now, illuminating and lucid profession panelists. Thank you. What tablets for insulin resistance? So I think, as we said, metformin and glitazones are the ones that have really shown to reduce insulin resistance. SGLT2 has some effect, but these are the tablets that we have. As I said, they are not perfect. They are not 100%, but as long as they are working and your sugar control is good, it's all good. But after that, we'll have to look at other treatments.
Arun, can I talk 1 minute?
Oh, sorry, Suresh. Yeah, please.
Sorry, no. I think it's just, I want to say, I really want to appreciate the effort of Rotary to do this kind of thing. It is just an excellent awareness program. I'm a Rotarian myself, and I work in the tech city in Coimbatore. And I've shown this initiative, what you've done. The banner has been sent from Dr. Harish Kumar. And in our Rotary, the tech city, I'm sure you're aware of it. We do a lot of work, but they are really wanted to take it forward with the initiative, what you have done. So hats off to you with your great work. Really appreciate it.
Thank you.
I think we have covered most of the questions. I think I can. So thank you so much, Harish. You can take over and from here.
Someone told to show all the panelists in a view.
How do we do that?
You ask Jojo.
Jojo ji can help us there.
Actually, you have to see the speaker view. Right on the top right, you have got a view button as there. You can just click there, and drop down is coming down. You can use a speaker view instead of gallery view. You can use the speaker view so that you can see all the panelists all together.
Let's see. So
on the right side, if you're using a laptop, I'm not talking about the iPad or something. I'm talking about the laptop. You have on the right top, you have a view button.
It's a gallery view.
Yeah, you have to put it in the speaker view.
Speaker view. Okay, let me just, I'm getting there. Speaker view.
Can you give Rotary and Jojo the sharing option? He will do it. He can do it.
Okay, fine. Then it is all right, because it doesn't matter. I will spotlight each and every person. That doesn't matter.
Or you can spot each and every
I will spotlight each and every person.
That is better. Yeah. That is better. One by one, you can spot Jojo.
Moderate. First, you can spotlight the moderator, Dr. Arun Menon.
Yes.
Yeah. This is Dr. Arun Menon. Yeah.
Hi.
Yeah. Then Dr. Chandini, madam. Yeah.
Thank you.
She is a professor of medicine at emergency medicine, head of the department at Kozhikode Medical College.
Thank you, madam. Thank you, madam.
Yeah.
And we have Dr. Charles.
Yeah, Dr. Charles Panikel. He is a consultant gastroenterologist and hepatologist at Aster Medicity, Kochi.
Thank you, Charles, for joining.
Yeah. And Dr. Suresh is a very good friend, and he's a senior diabetologist at Sri Ramakrishna Hospital, Coimbatore. Yeah. And Dr.
Rotarian.
He's a Rotarian, and we have Arun Menon is Rotarian, and this is Arun Menon, and as well as Dr. Suresh is Rotarian, and Dr. Ravindran, he is a past, he's a professor, he was an associate professor at Kozhikode Medical College. Now he is left to Oman, and he's a very good contact. He used to attend all our meetings regularly, and he's a very lot of research work he's doing from Oman. Okay. And
Thank
Dr.
you.
Mohan Shenai, Dr. This is Molly is a principal at Amrita Institute of Nursing, and Amrita Institute of Nursing. She's a professor, Molly. She's
you.
okay.
Thank you, Molly, madam.
Molly, madam. Okay. And Shenai is there?
No, he already left.
Because he's some problem with the any other.
Anjana
is already left. Anjana is a Mohan's Diabetic Center. She's one of the director. He does lot of research works, and they are in the India Diab study. They are doing. Yeah.
So thanks to all panelists and also moderator Dr. Arun S. Menon for the wonderful
Dr. Arun S.
session.
Menon is the previously he was in Amrita Institute of Medical Science. Recently, I think 1 month back, he has been promoted, and he's working as the head department of endocrinology at Lisi Hospital, Kochi.
Okay, thank you. It was
we
really
cannot see you. DG, we cannot see you. Your camera, we cannot see you, Governor.
Governor,
you can see me.
yeah. No, yeah,
video
you're
is on.
where is
Video is on. Video is on.
Video is on, but your camera is not.
Camera is not focused.
camera? You have to focus the
Camera
camera.
is focused on your face.
Oh, I don't know what happened.
No. No, the
camera would have gone to selfie.
Yes.
Yeah, now
Yes,
it's
sir.
fine. Yeah,
You're
now
back.
it's fine. Now it's fine.
You're
Yeah,
back.
No, it's fine. No.
Okay.
So,
on
on
the
the bottom of my heart, I'll thank everyone. And now, next is our.
Okay.
Yeah.
Now let me invite Rotarian Dr. George Muley, District Secretary General, to propose the vote of thanks.
First of all, it's already late. So first of all, let me thank our District Governor, Rotary Dr. Thomas Ovanikundal, for arranging such a wonderful meeting. Actually, it's the second of the line. Actually, it's a very good one. All the people who are here and enjoyed it very well. Now, our thanks to our chief guest, RI Director-elect Rotarian PDG Dr. Mahesh Kotbagi, who found time to join us for this and inaugurate the meeting. Then thanks to Zonal Coordinator, Rotarian PDG Dr. Ajay Kumar, who is also a close friend of ours. Then our thanks to District Trainer PDG Muralidharan, Vice Governor PDG Dr. John Daniel, other past district governors present in this meeting. Then thanks to Rotarian Dr. G. Harish Kumar, is the chair for the Preventive Health, for arranging a very useful seminar, very informative one. Then special thanks to our moderator and faculty, Rotarian Dr. Arun S. Menon. He has taught us how to moderate a good seminar, because I've been to many conferences. Even I have been a moderator also at various national conferences, but he has done it very well. He has managed, controlled everything. Thank you very much, Dr. Arun. Then we had an excellent faculty today, faculty for the seminar. Our thanks to Professor K.T. Moli, Dr. Mohan T. Shanai, he is a pediatrician, I think. And then Dr. Anjana Mohan, Dr. Ravindra Nevi, Dr. Chandni R., Dr. Charles Panakal. Actually, he was our colleague, both mine and Harish colleague at Pala once upon a time. Then our thanks to Rotarian Dr. Suresh Damodaran, who found this time to join us for our district.
Today he had 11 meetings.
Yeah,
Suresh
that's what I. Yes, yes, it was very good. All of them did very well. And then our thanks to all the assistant governors, district officials, presidents, and secretaries, and all the Rotarians who attended this meeting. Then special thanks to IT officer, because I think he's the person whom I have thanked the maximum. Both along with our DJ, I have always thanked Rotary Jojo as well as Brijesh. They are the pride of our district. And without them, I don't think during this COVID time we could have done anything. I don't think we could have done anything if they were not there. Anyhow, thanks to our MOC also, Dr. Tessie Kurian. Thank you very much.
Jojo, special thanks, because in the starting we had a real problem. Real problem. Someone some hacked.
Unfortunately, I'm very sorry. I don't think. I don't know how another person has happened to come here in this one. I don't think that the behavior is suitable for a Rotarian, and I don't think he's a Rotarian also.
No, it's from somewhere else. Somewhere else has come. Pakistan.
May not be
something
from here.
No, it's from Pakistan. Something and all. It's a hacked one.
Yeah, they were all. I don't know, something. I don't think, because they were not. I don't think they were a part of our Rotary family. Anyhow, we are very sorry for the disturbance they had created. Anyhow, I'm very happy that all the speakers and faculty had, they did a wonderful thing in spite of all the disturbances. They were putting so many things, scrolling on the presentation and all, I know. Anyhow, it all ended very well. Thank you very much for the nice cooperation from all of you. Thank you very much.
Thank you, Joji. Now, I think we can adjourn the meeting.
Yeah.
Yeah.
Especially, I think this is very much. Yeah,
Chairman?
no. We had first. We are very much. Everyone is having so much of apprehension for why this happened. There, some presentations got scrawled, lot of things. Then we also are worried. Okay, so
Dr. Harish, it was Jojo. Yeah, it is almost like a hacking or something. I don't know. It's all
yeah, everyone has told that it's hacking only. Some bad words and all they are using in our this thing.
I've locked the meeting for some time so that nobody could enter inside, and I've removed all the.
How could you manage this, Jojo? It's really special credit to Jojo for because we thought our meeting will get stopped in between. You were really
I think it was from Pakistan. There was something written.
something
Like that was going on. I had to lock the meeting for some time, and nobody could come inside. So I have removed all the unknown people in between, and then I've operated with the waiting room on, so that I can see each and every person. A person without a name, I didn't have permitted of it. So somewhere or other, we had a problem of around 10-15 minutes, and we could take care of it. Thank God. Sorry for the inconvenience for all.
Okay.
So once again, I thank Harish and all the organizers and all the faculties. Thank you all. Thank you very much. And I think the meeting, we can adjourn the meeting. The meeting.
Vamani, we had a small group actually. We had made a small group only for this meeting. All the panelists. So what we had to do, how we had to present. So Arun has started that group. So only for this meeting. So that is a very active. So they told how many minutes we had to do. So it is a very well organized one by Dr. Arun S. Menon. Special congratulations, Dr. Arun.
Thank you, Harish.
Thank you.
Good night.
Really nice.
Good night, everyone.
Good night, everyone.
Good night. Thanks.
Good night. Yeah.
Thank you, everyone. Thank you.
Thank you. Thank you, sir.
Thanks, Harish.
Right. Yeah.
Silent, mute. How much mute? Unmute.
The meeting is adjourned for fellowship and dinner
at home. Okay.
Okay.
Everyone.
Good night, sir.
Good night, Dr. Harish.
Yeah.
Good night.
Yeah.
Very well done. Very well done.
Okay.
Thank you.
Thank you. Hello?
I don't know. I didn't play it, no?
Boy.
ഉച്ചയ്ക്ക് എത്ര ഇൻസുലിൻ കൊടുത്തത്
ഇനി വിടാമല്ലോ
Dr. Muli, meeting it's already late.
വിട്ടോ എവിടെങ്കിലും സുരേഷിന്റെ ഒച്ച കേൾക്കുന്ന നമ്മുടെ സുരേഷ് മാറ്റി ഒച്ച കേൾക്കുന്നവർ തോന്നി
Let me check. Illa, he is not in the meeting.
It's not in the picture. I know he has left, but was he talking to somebody else?
No, his voice is not there. Thank you, Dr. Desi. It's very nice.
Thank you.
Thank you, Sister Alice. Thank you. There is many. Okay. Thank you all. Yeah. Actually 165, 770 വരെ വന്ന പെട്ടെന്ന് ഈ പ്രശ്നം വന്നപ്പോൾ കുറെ പേരങ്ങ് പോയി 10 രൂപ വരെ പെട്ടെന്ന് സഡൻലി
ആദ്യമായിട്ട് ഇങ്ങനെ ഒരു പ്രോബ്ലം വരുന്നില്ലേ ജോജോ ഞങ്ങളെ വിമന്റെ എംപവർമെന്റിന്റെ കാര്യം ഇവിടെ അനൗൺസ് ചെയ്യാന്ന് വെച്ചിട്ട് വേണ്ടെന്ന് വെച്ചു ലാംഗ്വേജ് ഒക്കെ കണ്ടപ്പോഴത്തേക്ക് വേണ്ടെന്ന് വെച്ചു
അയ്യോ ഭയങ്കരമായി പോയി ഓക്കെ താങ്ക് യു ജോജോ ഓക്കെ